available in the night. And in many of these cases, there needs to be some kind of remote monitoring. And that's one thing we've been looking at. I mean, we are primarily a research institution that's focused on different areas of computer science, different areas of artificial intelligence. And there are many possibilities in terms of how technology can be used to supplement the staff available or enable or supplement the lack of specialist doctors available 24 hours. And how can some monitoring, you don't want to call the doctor for every small thing. But at the same time, when it is really required, you want to make a determination to call the doctor. So technology can help. And supplemented by, we've been talking about telemed, and EMRA has done a very good job with emergency, at least ambulance services. Now in recent years, telemed is getting popular. And now we're talking about, like, can we go a step further and look at much higher quality of care, which ICUs need, also in some form enabled remotely. That's the only way to make these, the nice infra that got created actually help. If not, like, nobody's going to go to those hospitals, and they will still crowd those few large hospitals that surround and not go to these district hospitals. So technology has a role to play, and that's our primary interest. We have worked with many NGOs. We've started a center. In fact, the thread with CPR also is in the center. It's named after our chairman, Professor Raj Reddy from CMU, Raj Reddy Center for Technology and Society. We work with NGOs to create technology to help them through technology for their operations. And like, technology is some of the more emerging technology areas. Like, we're working with some NGOs on using images from mobile phones for cancer detection, oral cancer, for anemia detection by images of the eye and nail, detect anemia. There are startups that we have that use sound of cough to detect different conditions, including TB. They also tried to do it for COVID, but it was, I mean, by the time they could get it working, the wave had passed. But many things possible just by external examination, through sound, through vision. And so we're working with NGOs. We've been having threads with CPR also last few years. Dr. Satish is here. We've been having threads with Choice Foundation on how technology can help with their children's screening camp. We are having threads with a few other NGOs on, like we work with Grace Cancer Foundation on cancer screening. So there are buses that go today. A radiologist or an oncologist has to be on the bus to do many of the diagnostics. Now we're working with them to say, like, without an oncologist on the bus or a radiologist on the bus, can you diagnose oral cancer? We're doing for them only. There are a few other things we'll do after oral cancer. So we've been working, otherwise we're primarily a research institution. We work on with our research students, publish papers and conferences, and that's primarily what we do. But as an institution, we're very keen to see our technology mean something to society. So we work with industry. We have one of the largest startup incubators in the country. At this point, we have about 130 startups in our incubator in the other block. We kind of have our own product labs to create products out of research. So we've been doing many things over the years. And in recent years, especially kind of triggered by the whole COVID situation, we said we need to work with NGOs directly. We've been earlier trying to do work with NGOs, but more opportunistically. Now we are consciously going after, we have a center, we have a team. We work with NGOs directly, cultivate relationships, and jointly identify problems, and then see how technology can help and build it. I mean, so we have engineers in this group. So apart from what our research professors do, they will help with algorithm and such, but we have engineers to build a complete solution that an NGO can take and use. So that's what we're doing. So in that context, we're very happy that this is a topic that CPR has identified for this year's seminar, and not just identified. I mean, that's an area where I've been talking to them. There are very serious plans to do something tangible on the ground, and not long term, in the short term, in the next few months, get some things going. So very happy to be part of their thinking, and wish CPR the very best in their endeavor. And we will do whatever we can to support. Thank you so much. And welcome again to the campus. Thank you.
Thank you so much, Professor Ramesh, for that inspirations and the feedback and the little story about how things work and all. We really appreciate. So we've been talking about CPR, but let's understand what CPR is or who CPR is. So I'm going to call upon the stage Mr. Krishna Kotapalli, Dr. Satya Garimella, Uday Kumar, Dr. Raj Shekhar Koppala, right? So please. So let's introduce Krishna Kotapalli ji. He's a healthcare entrepreneur, trusted advisor, and entrepreneur with over 20 years of experience in the healthcare technology. He's a co-founder of Skyo Health Analytics, which was acquired by EXL, a NASDAQ company. We also have on stage Dr. Satya Garimella, Chief of Cardiology, clinical electrophysiologist at Baptist Floyd Hospital. Dr. Garmala has practiced clinical cardiac electrophysiology for past 20 years. We have Dr. Uday Kumar on dais as well, Chairman and CEO of Home Healthcare, serial entrepreneur, investor with 28 years of experience, and founder of OHOM and co-founder of Quinox and Fieldglass. Mr. Kumar has a deep understanding of global health system and is an engineer graduate from IIT and holds MBA from IIMA. We also have Dr. Rajshekhar Koppula. He's general and laparoscopic surgeon and director at Ma Sharda Hospital and has been practicing for last 10 years and has done more than 2,000 plus successful surgeries. So please give them a warm welcome and over to you guys. Thank you.
I'll just stand up. So thanks everyone for taking the time on a weekday evening to come and attend the CPR event. I think the event is going to be less about us, but much more about exploring various possibilities and getting distinguished speakers up on the panel who are way more experienced than us at healthcare. So we're looking forward to this evening. We're planning for about 2 hours. Controlling time is hard, but just be patient. So just, I'll introduce CPR. So CPR literally started April 2021 when we saw COVID in India. And Satya called one day, Satya called me and Uday and said, hey, let's start CPR and do something for India. And coincidentally, Dr. Srinivas, who's here, identified a hospital for us, Ames Hospital, and the project was actually $500,000. And I have to tell this joke. So Satya called us and said, hey, it's $5,000, 100 people, how hard can it be? And I said, are you kidding me or what? $5,000 per person is not possible. That's how the whole thing started, just based on what we would call a wish, a dream. And here we are, probably 18 months out, close to $1 million in commitments and 3 successful projects and many more to come. So very proud of what we have done. I think, and Uday will talk about this. So it's, so we believe in transparency, process, but at the end of the day, the entity that we actually help fund, and you'll hear from Dr. Rajshekhar, they make it happen. Right? We are literally the people who are enabling it possibly, but the heart and soul of how this works is our end asset, which are the hospitals. So if you can go to the next slide. So why we identified critical care was we did the market survey. You could do many things, right? You could ship ventilators. So 2 things we identified is there's a serious shortage of beds, critical beds in India, about 70,000. We started with a dream saying, can we do 1,000 beds in 5 to 7 years, which will save, about 20 million lives, which will require roughly $15 million over 5 to 7 years. And I think we are on our way. Within about 15 to 16 months, we have done about $1 million worth. And it always starts, this is not like business, right? You always start big with a dream. Even if you are short, you have achieved a lot. So, with that dream, we are on our way, and we'll talk about what we have learned and how we are sort of thinking about scaling our organization. If you can go to the next slide. So 3 projects that we have done, and Satya will talk deeper about, each of these projects and why they are diverse, what their makeup is, and what we will learn through the process. So 3 projects, as I said, they've roughly cost, we have raised about $675,000. We have another $300,000 worth of commitments for 3 more hospitals, which are in the pipeline. I think we heard 1 good news today from a corporate donor. So 2 more to go. So we are hoping in the next 2 months, we would have touched about $1 million worth of committed funds from various individuals who have given us $100, all the way to corporate folks who have given us $250,000. Right? That's how this happens, right? And we are getting organized about how we do this. Along the way, we have learned a lot, about how we execute on this, procurement, how to get equipment. I think the one point I want to make is none of us here are in this to make money or anything like that, right? We want to keep the administrative fee to less than 8%. We have some excellent partners. We'll talk later. Sferul is our execution partner, and how we actually pick the asset, how we pick our partners to make sure that every dollar, every rupee goes to the end. That's what we live and breathe by. So whether it's transparency, measuring the metrics after we do the work, that's what keeps the organization going. And we're proud of where we are, and we think it's the beginning of the journey. With that, Satya, maybe you can talk about the project.
So I'm Dr. Satya Garmala. I'm a practicing clinical electrophysiologist. So you can actually call me an electrician of the heart. That's what I do. I actually take care of patients who die suddenly. My primary specialty is taking care of sudden cardiac death. So I have a deep understanding about critical care and intensive care. And as Krishna was saying, we actually started our vision in a basement when I saw the second wave, and said, oh, let's do something. With the help of many people here, we identified an asset. We started with All India Institute of Medical Sciences. The magical call, I still remember the day, it was May 11th with Dr. Maheshwar Reddy, when he said, okay, let's do this. And it was a daunting challenge of raising $500,000, but we could actually do it in 28 days. We were very proud of that. And we actually executed in 16 weeks. It's a state-of-the-art ICU. I think it has all kinds of facilities, including provision of dialysis for simultaneously for 4 patients, state-of-the-art ventilators. They have negative ventilation rooms. I think it's the only ICU in the country, I believe, which actually has complete 100% fresh air. So very proud of doing this. Thanks, Dr. Maheshwar and Dr. Kiran, for your outstanding partnership in this. Having done that, we actually moved and did the project with Maharashtra Hospital, who started a COVID crisis program there, and they needed ICU. Similarly, a 10-bed, but we could accomplish 8 beds. Again, I think we did the project within 16 weeks. We executed and delivered, including civil works, and they're doing outstanding work, which is actually a live experiment, how we can actually deliver healthcare in a challenging atmosphere. You're away from the city, you don't have all the specialists, and how are we going to deliver? I think they have done an outstanding job of delivering and taking care of, I believe, more than 200 patients, with multiple patients on dialysis, with the help of multiple resources, which they're going to talk. And I think that's going to be a real learning lesson for us, how we can actually develop critical care in an aspirational district like this, because they are impacting multiple villages around them. The third project is we did with Dr. Satish, and because they are an established multi-specialty pediatric care. So it was a low-lying fruit for us to take. And they needed a high-end equipment, which we provided. And they impact multiple children, including orphans. And we are looking further for partnerships. So actually, it's my deep privilege that I actually could associate all these partners here. Deep thanks to them. And a deep privilege to actually share this vision with all the people in the audience here. And it's my deepest privilege to be in this compassionate shoes that we can actually deliver to the most needy people. I think it's a privilege. It's not something I can pat on my back, but it's actually a privilege that I can actually provide with whatever resources I have to the most needy person, which is the patient who's struggling. It's my privilege to introduce to Dr. Rajshekhar to carry on with what they're doing with Maharashtra Hospital. Thank you.
Good evening, everyone. I am Rajshekhar from Yagna Foundation. Actually, ours is a small group of doctors, and in the part of last almost 15 years journey, some more non-doctors have joined with us. We run a school, and also with the help of philanthropic donors, we recently started Maharashtra Hospital during COVID crisis, and it was basically a tertiary care, a secondary care. Till recently, when we came in contact with our CPR group, where they came and generously supported a kind of a tertiary care at our hospital. We run in a like a rented premises. It's like a free given premises. But our main motto is like we because I am a surgeon and there are some doctors. Suppose if you provide an operation theater, they are immediately ready to do a surgery. So instead of building an infrastructure our own, we during COVID crisis, we have taken an existing hospitals and we have modified, and with the help of CPR group, we have brought the resources, especially now we are primarily like Masharda is trying to be part of this experiment, like how we can take the critical care to a rural area. We know it is everyone who is in the healthcare, especially in India, that we know health is a challenge, that too in rural area, because all our expertise doctors and all our clinical equipment is focused in the cities. So, and the primary healthcare, basic healthcare itself is a challenge in rural area, but when it comes to critical care, it's almost nil. Suppose if a patient, say a doctor in a 200 kilometers from Hyderabad, if he develops some chest pain, it is very difficult for that area to have a setup where that sick person, say incidentally is a doctor, but to diagnose that you are suffering with a critical illness or it's just something gastritis. So that kind of facility is also not there to tell that a particular problem is a critical illness or it's a moderate, like a mild illness. So to start with that, and when we suppose say with the CPR group, Masharda has taken 10 beds and they are already operational. So like, yeah, first slide, we had a very enthusiastic and very happy event when our CPR group came, and we have inaugurated in the last March 20th, actually, because this is the first of its kind in that Vikarabad entire district to have advanced, say an ICU bed and ventilators and some equipment. So it was very enthusiastic to, especially for our team, for EGNA members and the doctors there and to the local people. So we have inaugurated, and then from the next, within next 15 days, we started taking patients into that 10-bed ICU facility, and almost we have treated nearly more than 200 patients in this last 6 months, and more than 6 critical patients who went on ventilator, and so like when same issue, like when we started a school 10 years back. All our professors, like one of my professor is here, they used to ask us, like, you are doctors, why you always talk about Vivekananda, bring some swamis to the college, or go to, like, we have taken some children, adopted them, and we used to go and spend with them, teach them. So when we started with the 30 kids, one of our well-wisher donors asked, like, what will be the plan for next 6 months or 2 years down the line? Then we said we don't have any plan. Then they asked, so then what will be the future? Suppose if you are not able to take care of, then Dr. Vijay is here. He's one of my friend. He told, see, we don't know what will happen to the future, but if today we don't initiate now, these 30 kids will be on the roads, on the streets. So like immediately after the inauguration, sir came and we had a meeting. And then what are you going to do that? Where is your doctors? So on that day, they got a surprise that there is no critical care specialist here. There is no critical care nurse here. There is no critical care or any therapist or respiratory therapist or any ventilator therapist. They came to know that, but it is a fact. In fact, we asked them all this critical care equipment, knowingly that this is one step. So we have not had any plan that this is the first step or that is second step, but we had a plan that with the good intention, all things will fall in place. So we have successfully like a 85 years old patient with small bowel resection was put on ventilator for 3 days, and she came successfully out of that. So even though the setup is very primitive in the sense of like manpower, so without a critical care specialist, without any ventilator therapist, still we could do whatever is possible. So this is one thing. And now the discussion is like, see, if there is 1 bed or 1,000 beds, the challenge is the same. Like, who will identify the critical illness in the patient, and when the patient is transferred to on the critical care bed, who will handle the challenges that starts, like a patient of like, we have taken an organophosphorus poisoning, a 35 years male. He was referred, like Tandur is 106 kilometers from Hyderabad. So patient was referred in the midnight to Hyderabad. He was on the way ambulance with oxygen support. So suddenly when he entered to Vikarabad, suddenly the driver and the relatives noticed that he is no more breathing. So generally it happens. 2 years back when I was in government setup, one day it happened, the driver brought that sir, patient is almost dead, so come and see and declare. So when I was in government setup, I just went and the patient was gasping. Actually immediately we could intubate and same thing happened in Masharda also. The patient came at 2 o'clock in the midnight. So I went there. It took for 5 minutes for me to go from my room to the casualty, because we don't have a emergency doctor. So I am the doctor for day and also I am the doctor for night. So and we have set up an emergency room where there is a laryngoscope is there, oxygen is there, but thing is the patient is not breathing. So I was in a situation whether to resuscitate or not. So but when I saw there is a pulsations in the carotid pulsations, so I thought let us give a try. So I was just looking for a laryngoscope, but the staff is so untrained, and because there are 2-3 people, but they are available only for day, because we use care very specifically for our OT and other things. So with some difficulty, I think all these delays, if a doctor is there, any doctor can say it's the fate of the patient who saved life. But ultimately we could intubate with those circumstances, and we kept the ambulance not go home, because it's almost patient was not breathing. We have intubated, but after that saturation started improving. So we thought there may be a cardiac arrest in the next 4 or 5 hours. So we told the ambulance to stay here. Anyway, he's going to die. And so you have to take back. So there was no response. It's an organophosphorus poisoning. So I went to my room at 5 o'clock after handing over the patient to ICU. But 9 o'clock, after the regular doctors came and they started finding like a patient is still alive, and he started some movements. So this kind of critical cases will come, and the challenge is with the clinical expertise with the doctors, staff, and also the other paramedical staff. So but luckily this patient, young patient, he was put on ventilator 5 days. We did tracheostomy and he came out and he went walking. So there was another case. Yeah, can we go next slide? Yeah, next slide. Yeah, there was just to bring the challenges with the examples which we faced there. Like there was a young male with bilateral obstructive uropathy. He was having a stone in the both kidneys, and almost right kidney has gone. He was just taking some painkillers, not properly diagnosed, not properly identified the problem for almost 1 month. So when his other kidneys started affecting, he landed in metabolic acidosis and some respiratory distress. So that kind of case we have admitted, and in the night. So by the time the rural setup, so if you order something creatine, it will come after 4 or 5 hours. So if you order something, it will come after some hours. So this kind of challenges will be there. And because we will not have in that kind of setup, especially in our setup, we will not have a immediate physician who can clearly guide us. This is a critical case, need to be like done this, that. So this patient was having high creatinine, more than 150 urea. So that patient was requiring a dialysis. So in the first of its kind. I don't know whether in the past somebody has done in the Vikarabad area. First of its kind in emergency situation, we have done dialysis to this patient, and that all credit goes to the CPR team because of their kind heart and the infrastructure they have given there. We could utilize that for this patient. So even to take a decision for dialysis, actually the nephrologist has to give an opinion, even though the lab will show that this is a case for dialysis, but we wanted. So that is a night. By the time we decided we don't have a technician, dialysis technician. So we have to put a dialysis catheter. After that, we have to call a technician. So we had that challenge. So with a lot of difficulty, we could. So when we have put the patient on the dialysis bed, so the technician got a doubt how much water I have to remove, because sometimes first dialysis, it's more they depend on the nephrologist opinion. So the nephrologist is not available for, of course, for any rural critical care. So I had a friend in the US, so I called him. So after some time he picked up the call, and so he has given some guideline. So then by the time the technician took a decision and did almost, there was a little delay, but still we could save the life. So after next day, there will be second dialysis, third dialysis. So when we are in the day, like the nephrologist in the US, so he is in the night. So again, for the next second or third dialysis, I have to contact another nephrologist in the Hyderabad. So this kind of challenges will be there, but with the difficulty we could do. But in this scenario, there may be like one day night, I think we have disturbed your friend in AIMS. So like we'll be searching, see what is happening to this patient. The fever is not coming down, this is not coming down. So having a critical care setup and without a proper skilled manpower, it will be like a day-to-day challenge. It is not a nightmare, but it's like a Herculean task. You are like going a uphill task. Otherwise it's a very simple job. Suppose any regular case, for us it's a very simple job. We do like routine thing, we diagnose, we do, and so when it comes to critical care, because even all we as a doctors, we are not properly exposed to a critical care kind of thing, because we see all stable cases. So there was another case of severe acute pancreatitis. Actually, this is a very challenging case we had. This patient came almost 200 kilometers to Masharda. Actually, he was from my village, Gadwal. He was very lucky that on the day one, when he had acute pain abdomen, he went to a gastroenterologist. He could immediately diagnose that it's acute severe pancreatitis, and hoping that when they have sent a report and the prescription of the gastroenterologist, I thought I can manage in my ICU, because the diagnosis is clear and the gastroenterologist has come to a conclusion. Because telling on phone to come and admit a patient is a difficult thing. After coming, you may diagnose something else and you again say go somewhere else. So we have admitted on the day second of the symptom. So we had a CT on, say it is on the 8th of November, he was admitted. So we had a CT showed it's acute severe pancreatitis, not necrotizing pancreatitis. So, but within next 5 days, patient deteriorated, and we were in a dilemma. So he was in sepsis, all limbs were swollen. So we have put a central line, and after 5 days again we have repeated CT scan. So there was no necrotizing pancreatitis, but it was still severe acute pancreatitis. But on the next day, he went on to ventilator. There was a respiratory failure. Already by the time of the admission, he was in a respiratory challenge. His saturations were 88 and urea was clear. So there was acute kidney injury and liver injury, lung injury. But we have managed from almost 8th to 21st. So from 19th of November, like say after 10th day of admission, continuously he was having fever, 101, 102, 103, 102 for 72 hours. Every hour, even when we go home also, there is a WhatsApp group. I think Sheshugar is also, sometime he was part of our WhatsApp group. So every 1 hour, the temperature, when we see the temperature 102, 103, and instead of meropenem, teicoplanin, polymyxin, first time we have used in our almost 15 years of medical practice. So we rarely use those kind of antibiotics, but fever is not subsiding. So now the patient is the patient is a laborer. He's a hamali. He has already spent a lot of money on medicines and also whatever the care charges we are charging. So now after 18 days of his hospitalization, the challenge comes, what further next? Then we have involved, incidentally in this case, we have involved online critical care support team from Bangalore. So it was a very fortunate thing to, especially for this case, because every day we had someone to share our what is happening. So this case actually, and we have involved infectious disease specialist to want to escalate the antibiotic dose and everything. So when the team has decided, like the critical care team from Bangalore decided this patient requires, is not improving, he requires further CT scan. Patient is on inotropes, NARED, he's on insulin drip, he's a diabetic pancreatitis, and he was on midazolam, he was on vecuronium. So many drips are going, and that patient has to shift to another center for CT scan. So it was a and what will happen in that rural setup, if you take one critical patient, so it's a very small hospital. Everywhere when you go to OPD, the attender will come and stand there. So you have to daily face the attender, and so you have to explain them that the outcome will be very bad. So this kind of challenges will bear in the rural area. I think have taken a lot of time. So just to summarize, it is a very challenging task. At least some people have taken a brave decision to go ahead, and definitely these challenges will be met with some right solutions in time. I think, I hope, and I also congratulate CPR, and also we had a very fruitful experience. We saved a lot of lives, and that's just because of people like you. So I congratulate once again, because they have started this discussion in the very beginning, after not after starting 1,000 beds. So one bed requires the same challenges, 1,000 beds require the same challenges. So I think, sir, you are very fortunate that you have started this discussion in the very beginning. So thank you for giving this opportunity.
Thank you, Dr. Rajshekhar. That was fantastic. Whenever you start a project, you start with an empty space. There's nothing on it. You can do what you want. But when you do the first project, there's a dot. And that dot defines what you're trying to do. The second project gives you 2 dots, gives you a line. The line tells you where are you intending to do. It gives you some focus, some ideas. But the third sets direction and commitment. So I think we had 3 projects, and we heard how we did. The first was complicated, very complex, the best ICU. The second was essentially the idea of somebody who's not started an ICU, and we heard the stories of how they essentially transformed from being a normal hospital to a critical care capability, and the journey that they had to go through and the amount of effort that went into it. Now, the third project that we've essentially done, Dr. Satish Reddy, was exactly the opposite, where we already had the critical care capability, and what all we wanted to do was do more, even more highly specialized, even further. And so critical care can be anything from really small problems to really complex problems. So we learned the diversity of the 3. What comes to question is, what do we stand for? What does CPR stand for? And what kind of projects do we take on? And how do we do these projects? And why do we select these projects? And we realized we're not picking projects. We're picking people. It's the project happens to be what is the need in the region. And that region determines how Vikarabad would work, This is how AIMS Bibinagar would work, or how Dr. Satish Reddy would work in Hyderabad, and how he would extend it to all of the centers. But it's the people that we believe in. So we are very fortunate that all the 3 projects, we had fantastic people who were driven by an incredible commitment and compassion. So we said our first goal is compassion. We need to find people with compassion, and 90% of our problems are done. Now, compassion defines everything that Dr. Rajashekar said, everything that AIM stands for, and everything Dr. Satish Reddy is doing. So that's become our core principle. We had to go a little bit deeper because we have to do a project that has to be delivered to standards, especially when you go to FCRA and even society. Society expects us to do certain things. So the next thing we look for is integrity. We're giving money, we're giving work, we're giving equipment. Is it going to the right beneficiary? Is it being used for commercial purposes? Is it even worse, not being used at all? So we had to have the idea of integrity, the purpose, the determination, the reason why this funding is required, the reason why this equipment is required. Now, in order to make sure we've chosen the right projects for the right reason, with the right impact, we needed to do an extraordinary amount of diligence. And our diligence is not a one-sided activity. It is not we doing diligence. It is together. It is together. It is us understanding what your problems are and you understanding what we're capable of, working within the constraints of the government and their regulations, and making this something meaningful to both. And the more we do diligence upfront, the more we can be sure that the benefit and the impact is coming right down the line. So it's an upfront activity. And like you said, whether you do 1 bed or 1,000 beds, the critical care things, what you put into it is the same. That's what diligence is. Diligence says, do we know what we're trying to do and what we're trying to accomplish? And can we ensure it in the very first few days so that all projects get done the same way? The last was actually something we learned again with experience from Dr. Raj on this Rajashekar and his team, is sustainability. It's one thing to give equipment. Equipment can last 15 years with some maintenance and some little bit of effort. Yep, you can take care of that. And on an average, you can see 5 to 10 patients a month. And that will take care of the numbers that you want, and you'll start saving lives because the situation will arise. But underlying that is salaries for people, equipment, maintenance, the consumables, the drugs that are required, sometimes transport, sometimes care beyond, sometimes unaffordability. And all of those create sustainable models from both sides, from the patient as well as from the provider. And if you don't fix that up front, then the impact of what we're given is lost. And over a period of time, the 15-year period becomes 5, 7, 3, 2, and everybody's stuck. And because we have moved away from the project, it's not hard, not easy for us to go back and do things. So we said sustainability. So these 4, compassionate, integrity, diligence, and sustainability, defines CPR. And strangely, that's all we stand for. We are not the critical care specialists. We're not the operators. We're not even the people who bring patients to the table. We're not the ones who treat them, and we're not the ones who ensure impact. We're not the ones who make sure that the society is good. All that is in the intent. So what we do is these 4 things. And if we do these 4 things well, consistently, without exception, with no idea of any kind of malpractice, and like what Krishna was saying, no commercial interest whatsoever, then we bring that discipline to all of us. It is not a discipline that is meant for just the people on the CPR on the dais. It's for everybody in this audience and every project that is being participated on. And so our goal is to say, if we do these 4 right, I think we have made tremendous progress in the idea of saving the 20 million lives that we talked about with $15 million. That's less than $1 per life. That's all it takes. It's like a catalyst. It's not saving it's not the total cost of the operations. It's all that we need to create the push to find these compassionate doctors with the intelligence, with the integrity, and with the ability to create impact. So that's what CPR stands for. We are very, very, very happy to be here. And this year, we have learned a lot, and we have a lot more to go. And as we talk today, we will talk about another model of how we can do things. So thank you again for coming. Welcome, and looking forward to interacting with you more.
Thank you, everybody. Thank you for that insight. So now I would request you to please welcome our keynote speaker, Dr. M. Srinivas Rao, Senior Interventional Cardiologist and HOD Apollo Group of Hospitals. Dr. Srinivas Rao.
Very good evening to all of you. Let me thank CPR Group for inviting me here and speaking a few words about critical care in India and how difficult it is to actually get the critical care to rural India. Let me congratulate CPR for doing a very, very noble thing, what they have been doing the last few years. It's not easy to mobilize funds. It's not easy to actually execute the project. It's not just funds, but it's also intention, noble intention, trying to perpetuate this noble deed in the society, which is very much needed. That's very important. And also it is said that you may feel that there are no funds for any noble cause. What happens in general public is I ran two projects, in a very little way, in a very subtle way, in trying to address the issue of pacemaker availability in India, and also a project which would fund the pediatric and pediatric population for surgery in a very, very subtle way. When we try to run these issues of donations to this kind of poor patients, I felt one thing, that people has to know a pathway where the fund, what they're trying to intend to donate somebody, reaches the right person. Most of the time in general population, that they're fearing that the funds are misused. In fact, they don't go to the right person. So if you can show the pathway that the fund that is being donated by any person is reaching the right person, then the sky is the limit for the funds. You will not have any dearth of the funds. And well, this looks very artificial for me to speak about the problems of taking the critical care to the rural population, because already you are doing it. You are surmounted all the problems, many of these problems. But having said so, because having given this opportunity to speak to you about the problem that we associated with the problem that is associated with rural health, is that we know that rural health is a problem in India always. We have problems with our primary health centers, where we are not able to do the basic need of medical care in the rural population, and then forget about the critical care that we are extending into the rural population. And that's because, number one, lack of infrastructure, lack of intention to work in rural area, lack of what you call mobilization of medical facilities to the rural areas. And that was really dismal care in the rural areas. But things are changing for good in India. In fact, a lot of things have changed over the last 10 years, both from the government side and also a compassionate people like you, like CPR, which are coming forward to take the critical care and best of the case to rural areas as well. As can I have the next slide, please? As we know that why are we speaking about this kind of rural health and rural intensive care to the rural health or the critical care rural health? We know India is full of diseases. In fact, if you look at the statistics, we have the highest infant mortality rate, which are trying to get it down and down, but we are ashamed to say that we have the worst statistics in infant mortality rate, and we have the worst maternal mortality rate in all over the world. In fact, only Africa is a little bit more than us. In fact, even Sri Lanka is far, far, far better than us in maternal mortality rate. We have almost trying to reduce this kind of infant mortality rate, which is very high, and maternal mortality very high for the last 1 decade. And what made the difference? the difference made a single oxytocin in presence in the in rural areas. When baby is delivered by the mother, most of the time they used to die of peripheral hemorrhage, that is hemorrhage from the uterus, which is not contracting. If only we could have a vial of oxytocin, we could save this. So small things go a long way in trying to prevent these kind of deaths. So a small difference makes a big vertical difference in saving the lives. Similarly, the proper what you call disease control and immunization in the rural health would bring down the infant mortality rate. Then again, if you look at what you call the bad status of India, 1/4 of the population of ischemic heart disease is located in India. And then this is not just urban areas, but in rural areas also. Commonest reported cause of death in India today, whether rural or urban, is cardiovascular disease or cardiovascular death. So there's a lot to actually save these patients when they are actually having this disease in rural or urban areas. We are the largest population of diabetes in the world. We call it diabetic capital. Then we also have the problem of hypertension. Every third person in the society is hypertensive. And then 1/3 of the population, as I said, is hypertensive. 1/3 of us are pre-hypertensives. That means only 1/3 are minority are normotensives. So where are we leading to? So is it just located to a urban area hypertension? No, it is also in the rural areas. What are we doing here? We are trying to actually try to not only prevent heart disease, but prevent disease, but at the same time, we need to extend our intention of unfortunate people, those unfortunate people who are actually succumbing to these problems. So the accidents also increase in number. And then when somebody gets an accident, somebody actually has an unfortunate accident in the rural areas, where is the problem? Where is the vertical medical treatment for him? Where is he may be bleeding to death, or maybe he may require a special vertical tension because his chest is compressed, or chest is actually having a problem with the lung. You need to actually act immediately, or you can do some first aid, or you can take him to what you call a nearest center. So this critical care, which is being present in rural areas, semi-rural areas, will definitely help in this kind of situations where they can give at least first aid and try to save the patient and be able to transfer him to a center where a definitive treatment is possible in trying to save the life. So now look at what you call the critical care beds. The critical care beds are very, very less in India. We are actually having a lot of death of critical care beds, not necessarily semi-urban areas, but even urban areas. We are poor nation, and then the rural areas, they are more poorer than the urban areas, but there is a flipping of this kind of poverty. In fact, the urban area, the poverty is more than in the rural areas now. Earlier, somehow they have gained some kind of prosperity because of better agricultural prospects in those areas. Then we have urban poor has become more than the rural poor. And in these urban areas where the poor are they're located, they not only have less ability to go to a critical care area, but at the same time, they also have multiple what you call comorbidities, and which make them succumb to disease much more than the rural areas. So we have not only a problem of the urban and then rural urban area where they are located in place where they can reach a hospital for treatment, different treatment for critical care, but they have no money to actually access this because the cost is enormous, and then they have multiple comorbidities as well, which make them much more vulnerable to disease and death. Now, if you look at the number of beds that are available, critical care beds in India and then abroad, you see in the United States, it is every 1 lakh population, they have about 35 beds. Whereas in India, it's about very minuscule, about 3. So we need a large number of these beds to be arranged, not only in rural areas, but also in urban areas. There should be a great increase in this kind of bed arrangements. Not only this, but we also we are lacking the personnel or manning. In fact, we have very poor trained intensivists, as our previous speakers were speaking about non-availability of critical care specialists. Yes, we have a big problem about non-availability of critical care specialists. Also, we have trained nurses, which are also a big problem. We have a big drain of nurses from our country. We have the problem of nurses who are getting trained as such, nurses numbers are lesser than what is expected to be there in the society. But more problem is they're migrating to other places because of better prospects. So trained nurses are also a big problem. Trained technicians are a problem. These are the problems which we are actually facing in critical care in India, both urban as well as rural areas. So there's a lot to actually do in this segment of training more people in the critical care area and also critical care nursing and technical personnel in the critical care treatment. So next slide, please. So if you look at what you call how critical developed, if you look at Florence Nightingale in this days as 3 years, she is the one actually showed a pathway to critical care. She moved those sick patients to the center of the ward where nursing station is there so that they can get a better care. So this is how she moved and showed a pathway that critically ill patients must have a better what you call care so that they are very near to the nursing station. So this is the first example you can show how critical care began, and then from there we have leaps and bounds of improvement in critical care. We have defined the disease, we have classified the disease so that according to the classification, according to the seriousness of the disease, we can actually give more intensive treatment to the patients. And we also have improved our equipment where the equipment actually not only trying to identify the patients who require a better or intensive care or those patients whether they are deteriorating or improving. This equipment also is being put to use a much more better way. So may I have the next slide, please? So we have the problem of cost. The cost that is involved in Western world and India is much more different than what we have here in India. In India, the cost is not because of the doctors or nurses who are actually manning these units. In fact, that is not very high. But in Western world and Europe, that cost is very, very high. What is most important for the cost is, I mean, the CPR should also know about, they'll be knowing about it because the cost involved is the equipment and then the investigations. Investigations are extremely expensive. And then the infrastructure maintenance also becomes expensive because you have to have a cleaner, you have to have air conditioning for these patients, you need to have disinfectants, all these things. This also, the infrastructure maintenance also goes in a big way in consuming most of our funds that we have created for this kind of projects. Now, the best way is to actually try to what you call minimize the expenditure in this kind of infrastructure by actually adapting a cheaper way of trying to adapt cheaper ways, not to actually ask for unnecessary investigations or expensive investigations, and try to use the funds in a very judicious way so that we can save the money for helping more patients. And as we see in this slide, an average cost in a day of in a government government hospitals is about 10 to 15,000 for the government, but in private hospitals is not less. It is almost like goes to about 50,000 to almost a lakh of rupees in a critical care unit, which is very, very difficult for any person to expend. So this is where we want such organizations like CPR to help poor people so that they can actually have the opportunity of actually getting admitted in these units and getting treated for these elements. So now, unfortunately, what is happening is the next slide. We have what is called a telemedicine that is developed, so that we can actually access more population in the form of what care of the patient at the bedside, where we can actually monitor the patient's care by better way of actually using telemedicine. And when the patient is getting shifted from one area where the ultimate treatment not possible, but is getting transferred to get treated in a different area, when he's getting transported, he is better what we call monitored by telemedicine, and also a central surveillance where an ICU which is manned by a skeletal staff can also be held by a kind of a central center which is actually giving them the guidelines of treatment, or maybe some kind of dictating that what to do when a problem arises in these particular areas. And also a virtual and telecare also is possible, and this is possible to actually extend to larger areas of rural areas and or semi-urban areas, so that you can have a better what you call care with the telemedicine. We have the experts in our audience today, an expert in who are actually sitting here, who have been doing this project. Dr. KP and Satyajit also had been doing this kind of linking up many of these areas of critical care around in India with a very fraction of cost what you have to do with the Western world. In fact, if you import these kind of things from Western world, you need to spend a fortune. But here they are doing it a very, very economical way and very effective way. Next slide, please. So despite these challenges of extending the critical care in rural areas, but the government and as well as philanthropic societies like CPR are extending their help in trying to come up with what you call a good care in the rural areas. Government actually has created what you call Mission ICU. May I have this next slide, please? Mission ICU. The Mission ICU recently launched by Government of India. Actually, it is a project, a kind of a project they launched as a experiment in northeast India, that is in Meghalaya, Manipur, and Sikkim, and also in central India like Maharashtra, which to facilitate the mobilization of resources in the right direction and also bolster the bed capacity and in the existing hospital in the rural areas, and then help assess the quality of kind of treatment they're getting in this kind of ICUs, and the quality of bedside monitoring and then bedside what we call treatment, and aids, and also aiding in the deployment of more intensivists in the area, and also creation of an extensive database so that we know how the things are working actually. Now look at this change what we have seen. Simple things like availability of medicine, availability, basic technology or basic technique of seeing a patient goes a big way in saving a life. For example, oxytocin being present in the rural areas brought down our mortality rate from almost like 130 to 97 in the recent year. So in over a period of let's say less than a decade, we could reduce the maternal mortality rate to a respectable statistics. Similarly, availability of simple things like a point of care devices, which I request CPR people to actually make available. Point of care things like doing a PTINR. Many people actually who have a valve replacement done, they die of what you call bleeding or valve thrombosis because they do not have access to PTINR test in the rural areas. They have to come all the way to city, spending almost like 1,000 rupees for the transportation, because the patient comes along with one attendant. They travel here, they go back, and then they have to spend for the PTNR as well, which almost like costs about 500 rupees or so. And then because of this kind of moving in and out of their place, they really get bothered. They don't have time, because unless until they work in the rural area, they don't get the daily wages. They can't skip away from the daily wages. They can't come. Then they will just keep taking the medicine without proper monitoring, and they usually get succumbed. In fact, we do not actually ask many patients to have valve replacement because of this problem, like management of anticoagulation. And then we feel that when they have a artificial valve, we call it a new disease, because that can actually be a new, because they actually can kill them if they don't maintain the valve properly. So only when those cases where it is not possible to further treat them medically, we ask them to undergo valve replacement. Now with this point of care of devices, where you can do with a single prick on the in a finger, like what we do with the blood sugars, we can have devices which can take PTNR. We also have devices to actually know antiprobenpy as well for diagnosis of heart failure properly, and also train people to how to do a CPR. I don't know how many of us in the hall we actually have taught general population about CPR. CPR must be trained to, must be given a training to everyone in the society. And I feel recently, I feel that it should be made a mandatory to any, not only medical colleges, but also non-medical colleges also, before their certificate of when the completion of schooling or maybe college, they must be knowing how to do CPR. This is a small things which we can say will go a long way in trying to save lives. Well, this, as we said, the CPR, they're actually having a hub and spoke, kind of a method by which they can link up many of the rural areas with one semi-urban area so that they can extend the help to many of the rural areas. Of course, they don't have to speak. I had really learned what they've been doing from the previous speakers. And well, when you say you are doing something for the benefit for the nation or for society, money is not the only commodity that you can extend to as a help, but we can give time, and also we can give our expertise. And then what does it cost? It doesn't cost much. In fact, we don't lose anything when you're trying to share our time or giving expertise. Even if it is some fortune that you are giving, the point is that none of us ever run out of something which is worthwhile to give to somebody else or share with somebody else. We don't run out of something. For example, if you are trying to share some of our fortune, some of our time, or some of our what you call skill to others, what are we losing? Nothing. But it is a great help to the society in trying to enrich the society and trying to give some help to society in order to ward off this mortality. So there could be no definition. Next slide. There could be no definition of successful life, as I say, that does not include service to others. So the best way that we can define successful life is that involves a service to others. So I'll end my article presentation with a short video which shows how the disease is chasing us and how best we can actually save this our society from this finding. The cheetah is chasing this unfortunate animal. The cheetah is here deceased, and the animal is the society. And then where CPR is coming and trying to protect this animal. Thank you very much. Thank you.
Thank you so much, Dr. Srinivas. So we have another guest note speaker, the keynote speaker, and that's Dr. Lopamudra. She's a certified corporate director, senior management professional, having over 25 plus years of experience. Currently, she is in a leadership position with Aditya Birla Group. She is general manager, CSR, ESG, sustainability, community relations, corporate affairs, external stakeholder management, R&R land, communication with Hindalco Industries Limited in Raigada, Odisha. So she will be, we've all heard about like, where is the lacuna as to where we are lacking, between the healthcare. Dr. Lopamudra will be giving an insight. She will be giving, a presentation about how the CSR perceives it, right, from the donor's point of view. So can we have Dr. Lopamudra up on the screen, please? Now, she's been traveling extensively due to her work and could not make it to, this symposium live. But we just asked her if she could be kind enough to be with us virtually. So over to you, Dr. Lopa.
Yes, good evening.
Good evening.
Good evening, everyone. I'm sorry for not being there present myself, but I greatly appreciated the warm invitation, grateful for the warm welcome. Many thanks for having me in this gracious evening. I'm really excited and looking forward to the session. And, I've been hearing a lot of doctors speaking on it and really giving the challenges of health in India when we talk about, critical care. And I would love to share my thoughts and insights on healthcare. And thank you, Roma, for all your support in having me here at the Symposium today, rather virtually. Respected dignitaries, seniors, and my dear friends, the entire context of this session is worth pondering on. As I reflect, the purpose of this session is to brainstorm on the opportunities and the challenges on healthcare, focusing on the critical care. And our focus at Aditya Birla Group is one of the major focus is healthcare. And we work extensively in our operational areas to provide best healthcare facility to the urban and the rural. Mostly we are set up in the rural background. So we do work extensively in that. I think, well, I see this is a great opportunity for corporates, individuals, organizations to partner in building a healthier India. So preventive healthcare is an important dimension for health that needs significant attention and investment from all sections of the society. Now, when we talk about critical health care, we work mostly in the aspirational districts, as prior to me, doctor was mentioning how this hub and spoke, and I totally do agree that this kind of hub and spoke model would bring India to to help building India and into a healthier India. And actually what happens, a lot of death happens in this area for not having the immediate ICU care for them. A lot of death due to accidents, a lot of death due to heart diseases, because nowadays these kind of diseases much more prevalent than malaria, dengue. And incidentally, I was traveling to Kalahandi, one of the aspirational districts of Orissa. The Kalahandi and Rayagada districts of Odisha are the aspirational districts, once known for the poorest to poor health and for hunger affected areas of Odisha, and very backward. But the current government and current national and state governments interventions, a lot of work had happened in terms of healthcare, in creating CHCs, PHCs, and then, DHH. But still, even in DHS, if you look at it, the ICU and the critical care is missing. And it is, unfortunately, yes, we have doctors. You don't even find doctors. So for our MHUs that is running in these two districts, in two blocks, we have to accommodate it by, Ayush doctors. India, that's a bigger challenge. No doctor wants to be there in the rural setup because here there is no network. And only a few passionate people like, CPR kind of, they can venture into these areas. And it's a need of an hour where CSR must utilize their funds, and not only in preventive and curative, but also into this kind of critical healthcare, system. And these healthcare system, what would be the benefit that in the hub and spoke? If it is in the district headquarters, the hub is there, then the spokes can be in various block offices, and further these vans can actually help them. It would be a great opportunity for corporates to actually explore this kind of healthcare services that CPR can provide. And I think, it is for CSR, honestly speaking, what we actually work extensively on ground on providing the basic healthcare facilities, like people of diarrhea, people in TB. Today I had a meeting with the collector Kalahandi for eradicating TB, because India has given a target 2030 to eradicate TB from India. So every state is working towards it. So yes, obviously these kind of initiatives are interventions are needed. A lot of awareness are needed also, in reproductive health, in you talk about, and this is one major topic, major work that we all at CSR and all the medical fraternity has to do work on, to work with reproductive health, child mortality, MMR, IMR, and those areas. And I was discussing previously with Uday, and it was nice interaction with him, because what is much more needed in this area is the child, the neonatal care and critical care for neonatals. That would be a great if that happens in these rural places. I think this is a blessing. They may think that God is here. So this kind of challenges are mostly faced in the rural part of India. Being from the corporate sector, we also look forward for more support, because what we are lacking is we don't have a proper information who all are working working in creating infra or creating such structures in in the rural setup, because most of the agencies or entities love to work in the urban setup. So I urge entities to move towards the rural. It can be a multi-stakeholder base. Other corporates can join this mission, and obviously I think the government can closely focus how this kind of critical care can be approachable and reachable to the tribal belts of Odisha, tribal belts of Chhattisgarh, Jharkhand, and of Karnataka. This multi-stakeholder based approach can help us to achieve the SDG goals in the near future, in SDG 3, where we talk about mostly, UN to reduce global maternal mortality ratio less than 70%, so that 1 lakh live births. By 2030, as we are saying, they end prevalent deaths of newborns and children under 5 years age, and all countries aiming to reduce this neonatal mortality to at least as low as 12%, 12 per 1,000 live births. Under 5 mortalities to least as low as 25% in 1,000 live births. And also by 2030, end of epidemics of AIDS, tuberculosis, as I mentioned, malaria, neglected tropical diseases, and combat hepatitis, waterborne diseases, and other communicable diseases. These are a few of the targets of UN. By 2030, reduce 1/3 premature mortality and non-communicable diseases through prevalent and treatment and promote mental health and well-being. So there are a lot of things, but yes, we are very keen on neonatal care, child mortality, because child mortality in the rural area is a very, very big trouble and menace, and not enough, as I said, not enough doctors. Today I was talking to, they said, community cadre, medical health provider, health officers, CHOs are there. I said, honestly speaking, do you see in any village such kind of a person there? No, because they are in the district headquarters and the interior villages are very far. And then, why do we even keep those? So such kind of hub and spoke model, what has been mentioned, I think is going ahead. That is the future, and that can cater to a large segment, of the healthcare in the rural part. So we need to make a significant contribution as far as our CSR capacities for specific projects, programs in identified public health priority themes that as I mentioned, critical care, women, child, nutrition, social determinants. So sharing few healthcare, in the trends that will change the country's healthcare landscape in 2022, as per me, is improved mental health treatment facilities, long-term, focusing on long-term sustainable healthcare solution, which I said, this critical care center, hub and spoke, and the vans, they are long-term sustainable healthcare solution, green healthcare practices, critical infrastructure, building infrastructure on critical care, investment in healthcare and technology. And this is one of the ways we can do. So as per me, I think, these are the few CSR trends that would be seen in future. As a healthcare ecosystem in India is actually characterized by extreme differences in quality across rural and urban. Private players can play an important role in bridging the gap and ensuring equal affordable access to healthcare services. And CSR initiatives are no longer just charity anymore, but it's a conscious attempt by companies to make a real difference in the community. And I urge all the members, those who are present today in today's Symposium, should give it a thought. Let us put together our thoughts and see how all of our efforts can actually give, show a light of hope to the Indian communities in the rural part of India, the tribal belts of India, as the urban communities are getting this facility. I think I rest my case here, and I'll give the stage to Rohma again.
Wow, thank you so much, Dr. Lopa. Thank you for sharing all those insights, sharing your viewpoints. making sure that people understand what is the point of view from the CSR perspective as well. We really appreciate that time. So not taking much ado now, I'm going to call upon the stage Dr. Satish Ghanta, CEO, Choice Foundation, Director, Little Star Children's Hospital, Dr. Kiran Kumar Godivara, Associate Professor, AIIMS Bibinagar, Dr. Satya Garimela, who's going to be the moderator for the panel discussion, and Mr. Uday Kumar as well. The discussion is going to be about like what's an hub and spoke model, what's the pilot process, what is the impact, and the kind of the infrastructure that we would be needing. So please welcome on the stage, and let's take it further then.
Hello, can you hear me? Is it working? Yeah, it's working. So we heard this wonderful stories from Dr. Rajshekhar, where we have a real life experiment going on in an aspirational district like Vikarabad, where we provide critical care, but how are we going to sustain? So there are many challenges. So we have 3 different experiments. One is a big hospital where there were already manpower was there. We gave an ICU. Another setting on the opposite was Dr. Rajshekhar's setting. Another setting where Dr. Satish, where he has expert clinicians, and we had to, enrich him with some more equipment. Now, how are we going to basically progress from delivering the healthcare? As our keynote speaker said, and Dr. Lopa said, one of the ideas which came to us is to enrich an hub and spoke model, and that's what I'm going to moderate. So, for the audience, Dr. Satish, would you define hub and spoke?
Yeah, so hub and spoke ICU, I would say, it's basically a level 3 or level 4 or a tertiary or a quaternary hub trying to service the level 1 or level 2 or a spoke model in a way which, right from top to bottom, the specialized care using telemedicine. So it's as simple as that. With the help of telemedicine, you're trying to extend the kind of expertise with the nurses, the doctors, the paramedics, everything to the rural areas using telemedicine. And if that level of care provided there is sufficient, well and good. If not, they get shifted to the hub. So that's the whole point, where the patient's safety is not compromised. But at the same time, one important thing is the numbers. If you say 100 patients, 90% of the times they do not need level 3 care. They do not need level 3 care. Even in the 10%, not more than 2 to 3% need a real ICU, who they think they are sick. No. So the need is, you need to identify the exact need, and that can be managed in the rural areas. And it's a small fraction of them, with the help of a mobile or an ICU on wheels, they could be shipped to the hub.
I was going to ask you the second question, I think, which has already been described by multiple speakers. So why do we need a hub and spoke model? I think it's fairly self-explanatory, because I think we have so many aspirational districts and such a wide population. There's no way we will be able to reach, so many services. I think this one way, by using a central hub and with multiple facilities, other place where you can actually transfer patients, we can actually provide the care. So I'm going to actually go to the third question, because I think this has been self-explanatory. Can Dr. Satish and Dr. Kumar, Kiran, can you define the requirements of a large institutional equipment needs for an adult ICU and also for neonatal ICU?
Yeah, thank you for having me on stage. Before defining the requirement for a large hospital, I would like to just concentrate on few things, like we need to basically define what is the requirements in that hospital and what type of hospital it is. And as Uday sir has already said, a lot of diligence is required to assess the institutional capacity.
what the current institution requirement is and what actually the turnover of the patients. Sometimes the institute may be located on a central highway where we need to have a trauma patients, lot of trauma patients will be coming. And sometimes patients like a maternal pregnancy patients may be coming because they're serving a lot of pregnancy and pregnancy related conditions, and sometimes the pediatric centers also. So we need to do a groundwork and then assess the needs of that hospital. And then a lot of even future expansions also we need to focus on whether that beds will be expanded. For example, say like a 100-bedded hospital, probably 4 to 5 beds are required to start with. Probably that may not be cost effective. Then we need to set up at least 6 to 10 beds to start up with. And then regarding the correct exact requirements, I think I have a slide on that. So when we started a project with the CPR team, then we started with dividing these like equipments into vital, essential, and desirable. So that's how we started with. So maybe I will just no, the previous slide, I think requirements for this is the slide where there is a snapshot of vital, essential, and desirable equipment. Is it there? Yeah, this one, yeah. So we started with dividing these equipments into vital, essential, and desirable, because not all equipments are really required at the vitally. Without that, also the ICU may function to a good extent. So we divided like vital equipments, like we need obviously beds to station the patients, and then ventilators. We don't need 100% of the beds, all beds ventilators, because we can't really start up with. We need always probably like 5 to 6 ventilators, and then rest of the beds is step down units. So that's how we can manage the patients in ICUs. And then infusion pumps and syringe pumps, probably 4 to 5 infusion syringe pumps, a combination of that and per each bed. And then we need multi-channel monitors. Monitors are vital equipments, requires all the beds are required. And to have a CNS. CNS is central nursing station. So this is always important, though few costs may increase a little bit, but always better to have it, because at a single point, the nurses or our doctors can actually visualize all the 10 patients or whatever number of patients in the ICU to just simultaneously see the vitals. So this is reduces the movement of the manpower and concentrate more into other aspects of the care. And also defibrillators we require vital. And then another important thing is UPS, that is uninterrupted power supply. This is sometimes maybe lacking in few places. This is vital. Because suddenly a power interruption happens, suddenly the ventilator sometimes may not have a good backup, and sometimes BiPAP machines, usually that doesn't come with a power backup. So always better to have a UPS. Usually standard is to have 1.5 kilowatts of kVA of UPS per power per bed. In a big setup, probably we need to have 80 to 100 kVA. That's what we set up in our hospital. And then other equipments are essential, which are required, like suction apparatus, echo machines with ultrasound machine, and alpha beds and DPT pumps, and reverse osmosis plant and dialysis machines, if we are planning to have a unit with starting with dialysis. And then desirable, yes, if we have these things, it is good to cater the patients, like mobile X-ray units and fiber optic bronchoscope machines. So this I feel the usual requirements. Apart from that, now even Dr. Srinivas sir also is explaining, like point of care devices have come. So that enhances a lot of care and also easiness of managing the patients now. Now even point of care troponin test kits are available, and test quantitative kits also available, and even point of care lactates, even point of care ABG is Rochers is also devised it, which is very helpful to enhance the care and provide better care to the patients. Thank you.
So let me sort of with the experience that I have, let me tell you the flip side. You know, it's beautifully presented. That kind of equipment, being a hardcore neonatal intensivist and a pediatric intensivist for the last 27 years, I've seen both sides of the story. So it's always nice to have the best equipment, you know, in the rural areas. But my slogan is very simple. It's okay to have a passionate heart. You know, it's very nice to have, you know, use beautiful slogans, rural ICUs, just like how the the Prime Minister said, you know, we need to have rural ICU beds, you know, big numbers. It's always nice, but I always feel that you need to have a sharp mind over a passionate heart. Very important. Why? Two major reasons. As I said, it could be a good political slogan, but what is the use? In the sense, you compare it to the best in the world. I've about 17 to 18 years back, I was working in Australia, where we had a beautiful system called nets and pets, where they could afford everything, right? But still, the whole of the state of New South Wales had only 2 pediatric ICUs, full stop. There were requests. No, this is the need. This is the population. That's it. You are getting only 2 pediatric ICUs. One is where I work. That was in Sydney Children's ICU. The second was Children's Westmead ICU. That's it. So the heart surgeries, everything was done in only those 2 centers. There were 8 newborn ICUs. They were spaced across. And even to this day, they stay the same. So it's all about how many do we need and where do we position our expertise. That is very, very important. Because see, the problem there is, you know, everything is controlled and you have a system in place where anybody can't come up with their own hospitals. It's a public system. But here, obviously, it's a private setup, and then you end up doing, you know, many things in many places. And you have a huge sort of a disproportionate use of the intensive care beds in different places. And as was earlier spoken, the number of ICU beds in the urban areas are more, and the rural areas, obviously, it's not there. So I would like to say there are 7 points. 7 points to say, yes, it's nice to have a rural ICU, but it's way better to do a telemedicine ICU where you have one hub somewhere which has got quaternary level of care, maybe tertiary level of care, and then service these hubs. I'll tell you 7 points. First thing is, let's be dispassionate about it and let's think through it. What is the frequency of need of these ICU equipments in the rural areas? What's the frequency of the intensivist need in the rural areas? I mean, beautifully, the surgeon has been, they've had a dialysis machine. Obviously, it saved lives, right? It did save. But how many times was it used? How many times was the ventilator used? How many times, if an intensivist was there, he would be twiddling his thumbs for 28 days. Am I right? You agree, right? For 28 days in a month, he'll be twiddling his fingers. So that's the point. That's the first thing. So what's the frequency of the need for the ICU team, and what's the frequency of need for the ICU infrastructure? At the end of the day, they've been so kind-hearted, and they get the money, and they what they'd love is my equipment, whatever I've given, it should go to the needy. At the same time, that money should be well spent, right? So that's the first thing. Don't get me wrong that I'm against the rural ICUs. What I'm saying is, let's adopt a better model, or the way forward, what it's been practiced across the world, and we can even do it better. The second thing, it's never about the machine. It's always about the man behind the machine. You should have trained expertise behind the machine who can man that machine. It's not about having the best of ventilators and the best of equipment in the rural areas. Who are there to man? How many intensivists are there in the city? How many intensivists there are there in the country? As Dr. Gar was saying, there's hardly any, there are few. So how do we utilize these resources in the best possible way? That's what we've been brainstorming, and we need to do it better. And as I said, fewer available teams and trained ICU specialists. And the most important thing I keep telling my students, because I've been doing this for 27 odd years, and even this day I learn, because every single day is a learning experience. You get a new kind of a problem. The cardiologist comes and says, this child has got, absolutely fine. There's no pulmonary hypertension. There's a small duct, but that's about it. But I see the child's heart rate is 180. The child isn't doing well. And, the perfusion is poor. The child needs inotropes. I know the duct is not, is clinically active. The child is in failure. I know that. But it's not about having the echo machine and the best cardiologist. You need to use your acumen all the time to see whether the child is in failure or not. So it's never about the equipment alone. It's the men or the women behind the machine. That's the most important thing. And it's always a learning process. Absolutely, absolutely important. Every day, even this day, we learn. And it's all about a teamwork. Let's imagine one intensivist in the rural areas. He's got nobody to echo his thoughts. You need to have a multitude of people. Every day, you need to bounce your thoughts off. So it's always nice to have a team and then work in a hub and spoke model. Then skill set utilization. As I said earlier, how frequently do those skills get used? And on a daily basis, if you have 8, 10, 15, 20, patients in the ICU, your skill sets are more. You use your, you have to do your central lines. You have to do your femoral lines. You need to learn how to intubate. You need to get them onto the monitor, onto the dialysis units, ECMO if necessary. So all these things, it's a constant process, right? Then monthly operational expenses. That's the big thing. Whether you use the machine or not, everything it's got a, you have to spend money. The machines have to be serviced. So that's an operational expense, which is this. And then getting the biomedical and the paramedical team in the rural areas is a challenge. And they also would want to have a sort of the children and everything. They would want them to be in good schools in the urban areas. So that's a challenge. And most important thing, which is not usually talked about, is acceptance of morbidity and mortality. I think all my esteemed doctors here would agree. It's a challenge. If something happens in the rural areas and it's one doctor, and if there's a death of that patient, they won't accept, they won't take it kindly. They won't understand that, oh my God, they've got the best equipment, they're really slogged. No, the acceptance of mortality, morbidity, if you have a team of expertise with you need a whole team, medical team, paramedical team, you need the admin team manning all these things. And it's a challenge. It's always a challenge. And it's always better that I would say that it's nice to have a superbly equipped hub and servicing all these 8, 10, 20, 50, maybe 100 with a good level, because as I said, 97, 98% of the time, you need level 1, level 2 care, which can be given in the spoke with your telemedicine, and the 2 or 3% can be wheeled to the hub for better ICU care. Sorry for taking such a long time.
So I think in the interest of time, we'll move forward. Dr. Satish, we've been working with you about this hub and spoke model to see what are the definitions of each of them. How can we spend our resources in the best way? Can we briefly, maybe a couple of minutes, talk about the spoke, what we talk, and what are the needs for the spoke and all?
I think from a hub and spoke level, a hub, I think let's not talk about it, because you got to have everything. You need to have a team of 7, 8, or 10 specialists. In the spoke, what I would say is you need only level 1 or level 2 care. Oxygen, yes. Non-invasive ventilator. I would say it's advisable not to have a ventilator in the spoke. A simple non-invasive ventilator. Why? Because the nurse can handle it. The nurse is able to manage. And then I am going to see this child from the hub, and I'm going to monitor this child closely, and I'll be able to tell whether the child is going to get better with the non-invasive ventilator or not. So just a level 2, a kind of a sort of a non-invasive ventilator, and all the paraphernalia which a level 2 non-invasive ventilator needs, be it infusion pumps, syringe pumps, oxygen, suction, everything. All those things are a must. But that should stop at level 2 care. And that one cost would be roughly about maybe 40 lakhs for one spoke, roughly about 40 lakhs. But many of the spokes that we have already identified, because we intend to do it from the month of March, April, many of the sort of spokes we already sat and identified and spoken to, they have some of the equipment, some of them have a majority, some of them have a little bit of equipment. So it could be anywhere between 20 lakhs to maybe 40 lakhs. So it is doable. So with that less amount of money, you could actually service more number of rural areas.
So we've been working with Dr. Satish about the financial model and what are the needs between the hub and spoke, whether we can actually provide multiple spokes in providing NICU care in the radius. And to give an example, I think Dr. Satish services sometimes patients who are 8 hours away. So it's vital to have proper communication systems and all. So I'm going to give it to the expert here, Uday, to further moderate on this.
The true definition of an expert is knowing when you don't know anything. So we have 2 experts here. Dr. Srinivas has got us into the room. I would like them to talk a little bit about what they've done on telemedicine and how that has changed. Sir, you please come here.
Dr. Krishna was an expert anesthesian. I just want to give a brief introduction. Thanks for coming on this part.
I want him to tell how critical technology, how dramatically
Hi, can you hear me? I'm Krishna Prasad. I'm called KP for short. That's my call sign. 3 years ago, we decided to embark on a mission to start tele-intensive care. And I caught hold of my colleague, Satyadev. He's an IT professional. And he used to run, what we realized is we needed security and connectability, reliable. And we were targeting 0.3 milliseconds of delay of any transmissible data, 0.3 to 0.6. So I went to Haryana, I went to MP, and I checked out what can be done in an intensive care unit setup for tele-intensive care. There was a need, but the problem was technology. Medicine remains the same, but technology is what will destroy a tele-intensive care unit. You have the best intensivist sitting at the hub, but there's no point if the technology fails. So I happened to meet him at a wedding. He used to run a cryptocurrency exchange in Arizona. That's the ideal model of technology and security. Transactions happen in milliseconds and they have to be reflected. So I expounded the idea to him and he took around 3 months to do his own survey and he came back and he said, let's do it. So we spent 1.5 years trying to look at what technology is available, how expensive is it. And we realized the present commercial technology available by major companies is too expensive to handle. We cannot afford it. And moreover, none of these companies actually developed the technology on their own. They bought the technology from an experimental success. So we went about changing it and looking at it whether we can run it cheaper, and we succeeded. So we looked at a small hospital in a small district, Mandal in Maharashtra. It was a 40-bedded intensive care unit. It was being staffed by Ayurvedic and homeopathy doctors. And they were running an intensive care unit. And there were physicians who used to admit patients and talk on the phone. So we suddenly realized they asked us to connect and see what happens. This was not commercial, it was completely experimental because we wanted to test our technology. And when we ran it there, we realized that there was no internet. So the internet person had to come from Pune to lay a cable there. And there was a bus twice a day twice a day. So if he comes, and he came once and he realized he doesn't have enough cable, so he went back. Practical problem. So how do we solve that? So that's where Satya came in, and he decided that, look, we looked at the amount of data being generated, and we optimized the data so that we could run a 40-bedded intensive care unit using a 4G Reliance SIM. We could see the streaming data, live streaming data of those patients in Hyderabad. So we could even do a small camera interaction with the doctors over there. There was a problem. We had a command center with 6 monitors and people used to sit over there. Then COVID came. Now, the government actually took over a lot of the hospitals in Maharashtra, and we had to stop getting data because that became very private and very important. But what we did was we succeeded in able to connect 40 patients using a 4G SIM. That's possible. Then COVID came, we sat back, we did nothing. We had to dismantle the command center because people could not sit close to each other. So again, he came in and he decided that the command center needs to be set to the cloud. So we placed a command center in the cloud. Then we had doctors logging into the cloud and seeing the patients wherever they want from home. That's possible. But so we could slot patients to doctors so that one doctor doesn't see another patient by mistake. So while this was happening, again, data restrictions for COVID came in. We could not see patients. And then the second wave came. By that time, we actually talked to certain manufacturers and we worked with them to find palm-sized monitors, tiny little ones, which you could put it on a holster on a swing from a hand. It was very popular for those days. You must have all heard about it. People used to have pulse oximeters. They just take photographs of their saturation, send it by WhatsApp to doctors. And the pulmonologist used to see around 40 to 50 patients. The turn would come, and then he would tell you that, look, you're very sick, you need to go to a hospital. But that's perfectly fine. But this was not real time. So the last minute panic of finding a bed, and when there was a lack of oxygen started. So we started deploying these monitors to various people's houses. Now these monitors were capable of live streaming data. I'm not taking photographs, I'm talking live streaming data to the command center, which existed in the cloud, which doctors could monitor. Now we of course had deaths, were people who refused to go to the hospital, but we could give 48 hours notice that things are not looking well. And you might need to go to a hospital, start looking for one. While we were doing this, there were people who were in their homes, not able to go out. So people came and we talked to people who were providing food, etc. And they could deliver it to that. But that's a separate story. But so this live streaming of data started, and we could actually monitor their ECG, we could monitor their pulse oximetry, their blood pressure, live stream, as you would see it on a screen in an ICU. And when we told them that they need a bed, if they did find a bed and they went to it, we could actually monitor them live when they were moving in an ambulance. So when they reached the hospital, we could give a summary of what had happened in the last so many days as a PDF document, and we could WhatsApp it to the doctor to know what had happened as a trending. That was possible. So this is what can be done. So you can monitor people at home, you can monitor people in the ICU, you can monitor them anywhere. And it's not expensive. It is not expensive. So it's very simple. If you have a senior intensivist looking after 10 patients in an ICU, he has skills to look after 100 patients if data is properly fed to him or her. It's not difficult. Now, hub and spoke model, in the sense that a hospital, a large hospital, can actually, we created this model for various hospitals that a large hospital actually adopts 2 small beds in each rural hospital, monitors their patients there, and ensures that that patient can come to them. So there's a commercial success too. It's possible. So you can actually monitor them en route when they're coming to the town, to the center, and have the data available to you. We do not believe this is the way of monitoring people, is to connect monitors, the syringe pumps, the ventilators, the defibrillators, every possible thing which has got a port should be able to be connected, and is possible. We do not believe that monitoring is putting cameras in front of patients or in front of the monitor. That's illegal, because there is a privacy issues there. And it is to be mentioned, to be condemned, because you would need a specific, how do you put it, consent from the patient that he or she may be allowed to be on a camera, and that you have to keep the data secure so that it is not misused. We believe that monitors should be directly fixed. And if a patient has to be seen on camera, the doctor should request and the patient should agree. There is a consent issue here. And the camera which we use, that it cannot be switched on from the command center. It has to be switched on at the spoke center so that it can be seen. The next thing to remember is there are more patients at home than in the hospital. And there are enough patients to be monitored at home. It is not just about acute care. There's a lot of chronic care health problems that are there. People being discharged from hospitals, people going home after sickness, elderly people, all of them can be monitored safely at home for a very small amount of money. So it is possible and it can be done. Anything else? I'm willing to take questions.
Just 1 second, just 1 second. The thing that I want to talk about the most is, we talked about 4 things. Dr. Satish had given us the 7-point system. We discussed the idea of hub and spoke being possible, but hub and spoke becomes reality not by just funding alone, but by technology. And what he's bringing up is a technology that I can assure you costs in the millions of dollars, in the millions. We're not talking about small amounts. And he's able to do it at a ridiculously low cost. So he has made something incredibly real that I genuinely believe will transform rural, urban, poor, acute, and chronic care. And I think we are thankful to you, sir, for what you've done. And we are definitely looking forward to working with you. Thank you.
Now, this is not imported technology. It's made in India. Let's be very clear. There's nothing imported. Everything. Syringe pumps made in India. Monitors made in India. That's it.
So we have done mostly by using Indian technology, Indian technicians, Indian professionals, everybody Indian, which we have done this entire activity. And we are done with a mission of doing it at the lowest possible cost. So the one of the things which Dr. KP has given always to us is reduce the cost to the extent should be affordable by a rural poor. That's where the whole journey started. We worked on the whole thing. So one more thing which he has missed it in the whole thing is we are looking at proactive healthcare rather than reactive healthcare, which I've seen mostly happening in India. The proactive healthcare is we would like to check patients regularly, and we have proposed to a lot of governments, state governments, that we want to do a proactive health check, like a maintenance of a vehicle or something. Human body can be checked, and we can centrally from the hub, we can actually look at it, what the kind of disease profiles he has got, and develop the whole thing, algorithm, to do the identify which are the people who require really ICU requirements, or which are the ones who doesn't require ICU requirements, can be treated home, can be treated at PHC, CHC, or any of these locations. That's what we are trying to achieve at the end of it.
Can I have one question, Andy? Can I ask?
Sure, please.
Can I ask? Yeah, I don't know whether I'm allowed to ask, but yeah. See, one important aspect is with the IoT, you need to connect everything, which is absolutely fabulous. That's the way. Now, the other thing is, apart from having visual images, obviously documentation. So having the documents and, recording the demographics. And for example, let's say, from March, we intend to start this, and initially maybe 10 units. And then his aspiration is 1,000 spokes. That's a good aspiration to have. But, them sitting in the US, they need to have a feed, a data feed, in the sense they need to have real-time data, in the sense how many children have been treated at each of the spokes, how many have been retained in the spoke, how many have been sent back home, how many have been shipped to the hub, and the demographics, as well as not just the demographics, even the vitals, because how have they been trending? So could you please just throw some light on that? Obviously, you would have done that as well.
Yeah, we did. Data is limited only by people.
Yes.
Okay. How much do you want to give, and how much do you want to keep? Name it. It can be sent.
You don't require to ship the data within the Indian boundaries. You have to do it. The servers are located in India, and you can actually access the data every point of view. There you will be given access to which demographics, which how many hub, how many spark, each spark has generated whatever you are asking for it. The entire data can be moved and shared as per the requirement, so that the people who are putting dollars in it
Yes.
can virtually see
How is their money being spent? Exactly.
What kinds of outputs are coming up,
Yes.
so that they are satisfied for what money they're putting on.
Yes.
That's
See,
very
Exactly. I think that's
the law states very clearly that the data has to be kept within the geographical confines of this country.
yes.
It cannot be stored anywhere.
Yes.
Even if you give it to AWS, they have to ensure that the data stays within this country.
Yes.
So you may not be able to see the real data, but you should be able to get a summary of the data.
Summary of that. Yeah.
That can be sent.
I
That's
mean,
not a
yeah,
problem.
because what they need is a
we
summary,
were
but
sending PDF documents of patients for last 6 days vitals every 5
Yes,
minutes data
yes.
in a trending form. I don't
Yes.
see any reason why we cannot send it.
absolutely. Yeah.
Name it, we do it. It's simple. Very
Yeah.
simple.
Because if we have, because in the hub that we plan to have, obviously we have to have a big monitor with where I can see the child and the doctor, and I can see the live streaming of the, vital signs. But in addition to that, if we can have a sort of a dashboard where you could have each of the spoke, how many children are being treated, what kind of this, and then how about the alarm systems?
It will reflect whatever has been set on the monitoring.
Set, yes, yeah.
See,
Because
the
for us,
FDA rules,
we are
the rules when you make a monitor very clear. You cannot change the settings on any medical equipment from a distant site.
okay.
It was temporarily removed by the FDA for 6 months during the COVID pandemic.
Okay.
It has been re-established again. So we cannot go through the data port
Okay.
to change vital ports of any medical equipment.
Yeah. The
Only
reason.
The person over there. No, just you can hear me. I
Yeah.
just want to tell a little story. I mean, I was in my second standard in 1969. Okay, we were all sitting watching the moon landing. So Neil Armstrong, Buzz Aldrin were circling the moon. They had exactly 3 minutes of fuel left to land the Apollo spacecraft on the moon. Otherwise, mission scrambled, they had to get back. Otherwise, they would be stranded permanently on the moon. So the ECG of Buzz Aldrin with his tachycardia, which is an increased heart rate, was received at Houston. So that was being sold by Sotheby's, but they couldn't sell it because it's biological data. But the fact remains is in 1969, people were sending vital stats from the surface of the moon to the ground in Houston. And we are now talking about sending data to the next room. I mean,
Absolutely.
we're a bit late in the business.
Yes. Very late. Very late.
We're a bit late in the business.
Yeah. Only thing is regarding the numbers in the sense alarms. As pediatrics, it's peculiar for us because 140 heart rate in a newborn is okay, but 90 in a child who's 10 is, is not okay. So could we set them as well so that
you cannot set them, the people on the site will set them for you.
yeah, that's fine as long as they can set it
You,
and then
you need to have a telecom network. You
Yes.
have to speak to them. Yes.
okay, that's understood anyway. Yes.
Within 3 milliseconds from the site to your place, wherever you are located, because it's hitting to my cloud server
Yes.
within 3 milliseconds.
Okay.
So it's a continuous data stream. So what happens is you will see on the top, and then you can take a decision and tell the person concerned. In less than 1 hour time you want to speak, you can tell him
This is what needs to be done.
We're doing that absolutely now in most of the hospitals in India. From our command center, our virtual command center.
Wow. Very, very nice, sir. Very nice. Very nice.
So I think we've covered the 3 elements now. We covered the idea, the concept and why it's needed, how to go about doing it, the equipment needed at both sides and what needs to be done, and the technology that's going to stitch it together. What's missing now is the conversation of the cost and the first project to be done. So I'm very happy to announce Dr. Satish has agreed to be the first hub and spoke of the CPR model. And he is essentially going to do 3 things for us: pediatric and neonatal care. He's also going to set up be the hub, and we're going to work with Sparrow and other people to try and identify the spokes. And our goal is to start the project, as he said, in April and run this project. But we will need the help from everybody in this room, including the telemedicine program and other stuff, to make this a huge success and then make this the model to take it to the country. And I'm very excited about this idea. And I think this is not only going to change. What we did was we proved that 1 times 1 equals 1. Now we're trying to prove that 1 times 10 can be 100. So the math goes away, but something else comes up. And that's what we're going to try and do. And so this is our first announcement that we want to make. And I genuinely thank you, Dr. Satish, for volunteering the program. Now, Dr. Kiran has also had some experience in this kind of conversations about telemedicine. He knows of something that I just want him to briefly talk about that as well.
So in the hub and spoke model, I would like to introduce one more dimension, that is a hub spoke in a dot model. Here the dot represents something patients. So sometimes I feel personally, there is a barrier between the dot which is connecting to the spoke. So how to connect this dot and a spoke? So something like my colleague, Dr. Sridhar Reddy, is in Nandyala, who is working on these models. Is developing an app which integrates these dots like patients to the spokes, because the first hour, that is called a golden hour of resuscitation, because the earliest time the patient comes to the spoke, reaches to the earliest resuscitation bay, that is the most important, because that is a time, very precious time we miss most often in rural setups or semi-urban setups. So I would like to just highlight his thoughts and ideas. Dr. Sridhar Reddy, I would like to just talk about. Just 2 minutes.
I'm Dr. Sridhar. I'm an intensivist working in Nandyal. We are a group of doctors who have set up an exclusively critical care setup in the middle of the town. The entire building is critical care setup only. No other departments are there. We don't even have a CT scan or an MRI also. So even for a CT scan, we rely on transporting the patient to the nearest imaging center and come back. So that is how we actually started up. None of the partners of the hospital are rich. All of them are from a middle class family. So we cannot afford to establish a hospital also. So each of us contributed to establish the hospital. So over the last post-COVID, actually, we started the hospital post-COVID. Over the period of 9 months, number of patients who are brought dead to the hospital were almost 35. 9 months. Over the next 1 year, it went up to, from the starting point to next 1 year, it went up to 50. So we thought that there is a clear-cut gap in transporting the patient from the distress to the hospital. So our Nandyal is a place with almost 2 lakh population and 19 square kilometer area. So within that area, one hospital is receiving 50 broad dead patients per annum. That means you can count. India, there are a lot of people who are dying every second just because of lacunae in the transport, not because in the lacunae in the number of doctors that are available. So I thought, why not we integrate the system? So I thought of it. Today, everybody is having apps. Even we can have an app to waste our money also with some kind of a casino, all those things. And we have an app for delivering food, but we don't have an app to deliver a patient to the hospital. So I thought we'll start off an app. Mine is a more of an innovative thought of this one. So the patient will be able to activate an ambulance or book an ambulance with just one click. No need to sign in also. Just click. The exact location of the patient will be available to the paramedic and the ambulance. The ambulance will go there, pick him up and get back to the nearest safe hospital. That safe hospital is always predetermined, most likely the hub that you are talking about. That is what I was thinking. But this can be done only within the 5 to 10 kilometer radius, because we are talking about emergency patients. So, but when we actually integrate it with the government ambulances like 108 or something, then it will be much more easy to transport to the nearest safe hospitals. But the point will be to identify the safe hospital first and equip it with proper equipment and manpower. So my experience of establishing critical care is I have established 3 ICUs so far over the period of 8.5 years. One in Pondicherry, 2 in Nandyal. Nandyal, one was a medical college. The other one was what we have started right now. So, sir, investing is something. Investing intelligently is a different aspect. So I don't need a dragger ventilator. I don't need a servo eye to invest to treat a patient in the periphery. All I need is a 7 lakh rupees ventilator, which can give me a proper modes, basic modes, which I can handle and get the patient out. Why should I invest 14 lakh rupees on something which I can do it with 7 lakhs? That is an intelligent investment. I don't need all the ventilators to be 7 paramonitors. I can have only 5 7 paramonitors and 5 paramonitors, and if possible 3 paramonitors. That's a good enough equipment to be for my setup. So we contributed only less amount. The entire setup, the entire building, whatever, of course, the cost of maintaining the building, all those things are pretty high. To get the doctors to Nandyal is a very difficult task, because everybody will be asking for high incomes, because they are coming into the rural areas. They don't have proper facilities. They have to leave their families in the cities, and the children will go to the better schools. So, but anyway, dragging the doctors to the peripheries is a difficult task. Of course, maintenance is also very difficult. So somehow we are actually doing it with a margin of less than 10%. Whatever the expenditure, we will be getting back only less than 10%. We are okay with that, because we'll be taking salaries also. Not that we are doing it for free or anything, but this is the effort that we are planning now. So integrating the ambulances, pre-hospital care, not just critical care is a very good setup when the patient comes to you. But before the patient comes to you, there is one more step called emergency medicine. The patient has to reach to a place where he is stabilized first and then shifted to ICU. So hub should be a place where a proper critical care setup is established, but spoke should be a place where a proper emergency medicine person is available. He has to stabilize the patient. If he can manage it there itself, that is well and good. If he cannot manage, shift him to the hub. That's okay. But getting the patient from his house, an apartment where nobody is able to help the family also, getting the patient into that spoke that you are talking about is a challenge. And it's a big challenge in India, especially because no apartments are having a proper evacuation facilities, very less spaced stairs, no properly equipped elevators or anything. So every step is a challenge. We need to train the paramedics such that they can actually transport the person without any much of a harm and as soon as possible. So integrating the entire thing, when we can get a food with Swiggy, within minutes. Why can't we get the patient to the hospital? That is what is my thought.
Thank you for this wonderful discussion. We learned so many things here. Say the lakes of a small lake would harness few fish, but the lot of lakes join, it forms an ocean. And actually the ocean of social consciousness can get a tsunami of good healthcare in our country. Thank you.
Thank you, everybody, for being such a lovely audience. And we're going to move on to our second panel discussion. So I'm going to call upon this dais Mr. Shivaji Chattopadhyay, CEO, Cancer Centers of America, Dr. Ujjwal Raj, President, Yagna, Krishna Kotapalli as a moderator. We're going to be discussing about what are the impact measurements, what are the metrics, the SOPs and the procedures that we would need to have to implement this hub and spoke successfully.
Hello. So thanks, Dr. Shivaji and Dr. Ujjwal for taking the time. We'll try to keep this short, maybe about 15 minutes or so. So maybe we start with, I think that what we're going to try to do in this panel is Dr. Shivaji is in the commercial sector, right? Industry best practices there. Dr. Ujjwal, is with Yagna. So we're going to sort of do some banter around how industry best practices are done in the commercial sector, how it's being done at Yagna, and see if we can come to some common consensus of what impact metrics mean, how do you gather them, who are the stakeholders, so on and so forth. So that's the intent. So maybe Dr. Shivaji will start with you. Just maybe a brief introduction about yourself, like your role, what you do, right? And then as you think about impact metrics in your corporate, in your role, who do you think about the stakeholders that you're trying to satisfy, right? There's your management team. So if you can talk a little bit about that, that'd be great.
So good evening, everybody. I'm Dr. Shivaji Chattopadhyay. Basically, by training, I'm an intensivist. Post that, did my MBA from IIM Calcutta and Harvard Business School. So for me now, impact matrix is on the other side of the table. So if I explain impact matrix as an intensivist, my speech will differ. And if I talk about impact matrix as a CEO, it changes. So I'll start with the devil's work, where everybody hates the CEO of the hospital. So there was a great discussion. There were a lot of value adds, my seniors in the field of critical care who shared. Now, when we run a business or an enterprise, I always say, and that was one of the things I always shared to CPR, impact matrix is a big and a very important topic. So if an impact matrix is not initiated on day one, it is bound to fail. So I go with impact matrix in my organization on a simple fundamental of IPO. I use impact matrix on I, that is the input. I use impact matrix on P, which is the process. And ultimately, I use it on O, which is the output. Now, whether it's a dollar coming from charity or it's a dollar of a promoter, I have to use it. And when we sit on the other side of a table of a profit-making organization, that dollar has to be used intelligently. So impact matrix in form of input is everywhere. We start with the space of an ICU. Do we really require 10 beds? Do we really require 6 ventilators? Do we require 5 paramonitor, 3 paramonitor? So first it starts with the infrastructure, where we analyze to the depth, and because the corporate world, we always go at the end with ROI. So it's not a bad. I always call ROI as a financial discipline. It has to be there on a philanthropy institute. It has to be there on a charity institute, because for a charitable institute, you can't always go and ask money. it has to be a self-sustaining. So impact matrix in input is first all the infrastructure details which I require. What less investment, what maximum output. Now moving into the next is, do I really require 10 nurses? There are different fundamentals. So as an intensivist, we talk 1:1 nursing, 1:2 nursing. In input, I also take into account the management, because management has, so there are some tangible benefits they see and there are some intangible benefits they see. Now moving into the process. So once you complete the input part, the major impact matrix, which many times we miss out, whether it's corporate or in public private, is the process part. Yes, there we talk about dashboards, but very few times we talk about care paths. Care path is one of the major impact matrix in the process part in critical care, which we really miss out on that. So do we really monitor it? If monitor, first of all, did we make a right care path? Do we actually make a precision care path? Because the more we have a precision care path, your first eye gets changed. The major impact, if it comes on the care path, your eye impact matrix also reduces. So with less, you can have more. You can use it more. And lastly, on O. So O is a very versatile thing. We only monitor outputs. We give presentations. This data is trending this data. But impact matrix, when it flows from I to P and then ultimately it goes into O, and this has been always a debate in IIMs, that when it reaches O, it is almost like semi-baked. So do we actually take out that, do an analysis, come back to the process, correct? Now, sometimes it might also lead us to I also. Like somebody said, do I require a 14 lakhs? Yes, you might require a 14 lakhs ventilator, because many times it might happen. Yes, impact matrix might say there is a 7 lakh ventilator. Now, there are cath labs now available at 1.5 lakhs. We have a very senior cardiologist, Alan Just, I have to define the name, but definitely sometimes this impact matrix on I do define what the process will define and ultimately O. So my humble request to CPR, you have a great vision. You want to set a hub and spoke ICU model, but please have this impact matrix from day one. It's not only to do an identification of a project. It's most basic. You can identify because you have a plan, but ultimately impact matrix in one word, it's a very big scientific term. It's spoken in every leading B schools in the world. But I call impact matrix in a simple English word, that's discipline. So should I buy? Should I not buy? Should I buy 10 beds or should I buy 5 beds? Should I have 2 dialysis machines or should I have 1? Why should I buy a dialysis machine? I can bring it on a pay-per-use model. Why should I block it? So there are ways. So it's a very different world when you are sitting on the other side of a table as a CEO, and that too of a profit-making organization. But people always use this quote unquote word corporate. I think every parent is a corporate. Corporate is discipline. It only teaches us you do everything in a disciplined way. So all father, mother, all of us are corporate. So it's only a term which is given to institutes who does things discipline in a disciplined way. And I always believe, and I always tell that every charitable institute has to be a corporate, because you have to generate your resources to run. So I was seeing some presentation here where the important part of impact matrix is left at the last, operating expense. That's the most important part of impact matrix. That should be on the top. If you don't focus on operating expenses, trust me, you will not even have oxygen to breathe and your institute will shut down. So it's a reverse. Why we put the capex on top? You have to have the opex on top. So that's why people usually say, and quote unquote, there might be some financials, and unfortunately, when you go through the business schools, you understand that's why the balance sheet is made once a year. Profit and loss statement comes every month because we see how much we earn and how can we maintain it. So it's a very great thought, CPR team, and I'm honored. But my humble request to you is, since you have told me to speak on impact matrix, please keep focus on two things. First, figure out how do you manage your operating expenses. And second, bring in a discipline, and CPR should be a corporate CPR. Over to you, sir.
Thank you, Dr. Shivaji. So actually what is interesting is, after our AIMS project, we asked Dr. Shivaji to help with procurement, and he just got prices slashed. Right, so he helped us with the Masharda negotiations, and your eye on just the financials and stuff is really good. So same question, Dr. Ujjwal, to you, right? You all did not have one, so you had to, after you procured, and Rajshekhar was telling all the stories. How did you think about impact metrics? Who do you think are your sort of, I've got stakeholders, and how did you start thinking about putting something? I know it's work in progress. Maybe you can chat about that.
Yeah, thank you, Krishna Garu. So yeah, it's very much work in progress, and I mean, bang on the point that we should start thinking about it right from day one. Maybe we are already into 6 to 8 months of implementation, but yeah, we have started thinking about how to really assess the inputs required and the efforts that we are putting, how much yield that we are getting, and what different parameters that we should monitor. I mean, and slowly, I mean, I should admit that we are not really collecting all that information as on today as I'm speaking, but the direction is in that. So we started having a few feedback, patient feedback in the first place, in the sense, what are the aspects where they felt it was really the most valued part of the service, etc., the qualitative aspect. And then we already have the digital processes in the hospital for OPD care and admissions. So we're extending that also to monitor the entire ICU processes, so that every part of critical care, because here we talk in seconds and minutes. So every vitals and the machine statistics as they change, I mean, the parameters that we monitor. So if they can also be digitalized and are available to the doctor. So we were having the discussions in-house to, and also the other aspect, I think one of our earlier speakers has spoke about even capturing the patient background information when they get admitted. So maybe some of them may land up in an ICU after being electively taken into the hospital for a surgery or for any other care. It not always be an emergency landing in the hospital. So in either case, if it is an emergency, sometimes you are in the rush of attending to the patient and you don't collect all the background information in the right and systematic manner. Sometimes time doesn't allow you to do that. But in the other case, if it is a routine OPD or in the rush of OPD also, sometimes even for a normal case, you may not. So, but identifying which are those critical parameters for us to assess the impact after 6 months or 1 year or 2 years, if you don't capture those patient characteristics. So we are thinking in this, and if I can, yeah, so from a slightly different framework from a rural community institution that we are running. So one set of indicators for the clinical team, the decision makers on the spot, handling the patients, the doctors, the intensivists. So a set of indicators which should feed into their day-to-day and maybe minute-to-minute or hour-to-hour decision making. A second set of operational indicators for hospital or ICU administrators, focusing on the needs, the type of equipment, the type of manpower, etc. And then going beyond the institution on impact at a community level. So, and this is, I think, largely for policymakers, donors, or anybody who's thinking big beyond one particular institution, like everyone sitting in the room. Next slide, please. So just put together some parameters that we are looking at. So profile at presentation, what type of cases are landing in our place, in our institution? So what are the various types of profiles? Because customizing, as our senior doctor was mentioning, the presence of oxytocin made a lot of difference to saving lives of so many women reducing maternal mortality. So what type of medicines, emergency medicines, we should house or stock in surplus, and what other type of medicines or other tools and services we can have in a slightly lesser, not more optimized way, depends upon what type of cases land in your clinic or in your ICU center, specific to that particular region. And every region may have slight variation also in terms of the type of cases and what stage they are presenting. So like our friend has mentioned, so coming at what stage of criticality they are landing in our place, then the casualty vitals in the first presentation. What are the indications for ICU admission, be it emergencies directly landing in your place, or is it elective to emergency conversions, post-operative, or in any other medical deterioration and during the hospital stay. So what are those indications that are bringing patients? Then of course the case profile during the ICU stay, how many days, what are the critical supports needed, how many critical episodes occurred during the ICU stay. Going up, and Rajshekhar described a couple of cases where for 5 days, 7 days they were fine, but then suddenly there is a deterioration, and again you mobilize your efforts to bring them out. And equipment usage stats, I think, again, so our senior colleagues have mentioned how live streaming of data coming from these equipment can really inform the senior intensivists or the clinicians managing the cases about not only the presenting, and may also be a predictive element in that. We can always build that predictive element into that if you can have continuous streaming of statistics. But I think even we were checking with our equipment that we have, like, can we really pull out the data from the equipment? Does it store? I'm sure nowadays every equipment comes with a chip and it stores the information. So can we really take it out, even at least to do a retrospective analysis? If not, of the 100, 200 patients we have dealt in the last 6 months, how the various vitals and parameters have changed. But I think there are some limitations, and then there are some technology aspects that need to be looked at. So I think these are some of the parameters that clinicians would need on a regular basis. So having them readily at the disposal becomes very important. Next slide, please. These are some operational metrics that as an institutional head or an ICU management need. So what are the key cost areas where like our money is going? So we have put some indicative figures from our own limited experience, plus or minus maybe 10 to 15%. So the electricity cost, the equipment, EMIs, the maintenance, oxygen supply, etc. It could be, as again, as in our particular case, we because we have got the space not on a rent, maybe that element is not here, but in some other cases where we are operating it in a rented premises or in any other situation, maybe those other cost areas may come. These are only like an indicative ones from our angle. Then what has been the cost per patient? Like how are we able to manage it vis-a-vis the outside segment? And again, this may be become more important from when we are talking at a charitable angle, and being in a rural area where the affordability is a very, very big limitation. I don't know if you have noticed the slides when Rajshekhar was presenting, we mentioned what has been the total bill and how much the patient could end up paying. And so it also adds a little bit of burden to the institution from a sustainability angle, as you are saying. And are we able to really bring down the costs compared to an urban setup where, all the discussion that we just had, only if you need to go to a hub, you need to go. If you are able to be managed at a spoke level with maybe much, much lower cost, that is what we want to offer to the poor communities, or even, I think when it comes to critical care, everybody is poor. All your fortunes can just vanish with one episode. I think that's how still we are in our country. So, and I think our cost analysis for in the last 6 to 8 months in our center, we can say that I think we were offering our services at 50 to 60% less than what it would have taken in an urban setup, which is 60 kilometers from Vikarabad. So that has been our initial take. I'm not claiming anything, but that's our initial. And then of course the material and the manpower, we talked a lot about those things. I'll not spend much time on that, but I think the typical challenge here is you cannot leverage volumes in a rural setup because you will not be having a flood of patients. So if it was an urban ICU flooded with patients, maybe you can bank on volumes when you're buying your consumables, when you're buying your equipment, spare parts, etc., maintenance related things. But in a rural setup, you will not have such a heavy flow. Hence, you can't bank on volumes. So material cost and consumable cost is something that maybe partly institution takes up, but it also goes to the patient also, the higher cost. So that is, I think, one aspect, how we are sourcing our material that is directly or indirectly needed for the critical care. And then, of course, manpower, the skill gaps and bed nurse ratio. I think we are right now operating at 1:5 and to sometimes 1:8 nurse bed ratio, because we can't afford 1:1. I mean, that's a dream, but not sure if we over the next 1 to 2 years. So we are focusing in one point, which we were discussing is, I mean, where CPR's contribution has been tremendous is, we have at least started training 15 to 20 nurses in critical care management, which never happened before in that particular region. Not all of them may stay with us all the time, but even if they go and work in other hospitals, it is actually, we are creating a resource pool of basic critical care management in that region. So that way we feel that, yeah, that's one definite impact, but we need to work on those aspects. And lastly, just next slide, please. Impact indicators, looking beyond the institution, how our center or our facilitator services are contributing to the community. So to start with, we need to have good profile of whom we are serving. That is where the demographic, psychographic, or socioeconomic profile becomes very important. So to see that at least whom we are serving, I admit that we still not gathering very good data on that, and we looking at processes to improve it. At the very basic level, I can say that 58% of the cases we handled were female patients and 42 were male patients, but much more profiling would really help. And we could reach out to nearly 125 villages covering 25 mandals of the district over the last 8 to 9 months. So in terms of a geographic sense, I think that was, we really felt glad that we were able to serve a little wider geography. Life saved, again, not in a typical medical or so economic terms, but simple definition of those lives that would have been lost had this center not been there, because maybe by the time they reach a higher center in Hyderabad, so at least a good number of them we feel that we could have saved. We have saved and avoided so many trips to Hyderabad, and cost saved for the patient, as I said, 50 to 60% compared to the city. And so these are certain things that on a patient side, on a community side, we think that we should have. These are not an exhaustive list, but I would say that's some way to start with. So this is a different framework that we are looking at.
Oh, thanks, Doctor. So Dr. Shibaji, maybe the last question for you. So how do we do this at scale, right? So the processes of doing this in Mashallah might be extremely manual, front desk, somebody's writing, getting that information and so on and so forth. You're running a large corporate setup. So if you were to think about just the processes that can be used to scale this, and be able to gather the metrics and so on, how would you think about making that so that what we want to try to do is at least be, if you do 10 of these, right, have some basic templates, but as automated as possible to the extent possible.
So your template or matrix, you are looking from an MIS perspective or a clinical MIS, because the templates are quite different.
Yeah.
When you ask for a clinical management information system, the vision totally changes. And when you are talking about a general MIS, then it changes. So what is your,
general MIS?
General MIS.
Yeah.
So see, general MIS, I feel with the scale and everything, there should be around 8 or 10 max parameter, because for us, when we in corporate chains, we have MISs for every verticals, every department. But if you really want to have a deep dive of impact metrics in management information systems, and I'm taking out the clinical part of it, okay? So in this discussion, I heard, as sir was telling, basic 8-10 parameters will do, and it can be manual. Why to invest on a digital platform just to gather basics? So you can have how many patients it came, correct? Their demography, like male, female, they're capturing. And what is the bed utilization scientifically? See, you can give 10 beds. Bed utilization is a very versatile parameter. From units, when people come and ask us, okay, we have 90% bed utilization, can you give us few beds more? But do we actually have a wheel in and a wheel out protocol when we are actually taking a patient in an ICU? Because there's a cost. Whether you maintain one nurse for 8 patients, there is a running cost, and there has been a fixed cost, because these are very critical resources. You cannot have, and my thought is, when you are replicating it, it should not be more than 4 or 5 beds, because as intensivists, the more you give beds, the more we demand. And that's why the split ICU concepts came in. Okay, we have a cardiac ICU where the neuro patients cannot go in. We have a neuro ICU where the cardiologist cannot enter. These are all what you call luxury. So you don't need automation. You can have a management template, which every day end, the report comes to whichever person you are. And there has to be, when you have a remote, what you call social promoters, I'll define CPR as social promoters, right? So there has to be random audits coming out. And these 5-6 parameters are quite well enough when you have a very robust utilization. You have how many patients you have treated and the length of stay. See, keeping a patient 6 days in an ICU or 8 days in an ICU is for some people, oh, there might be really sick patients. No, it's not an actual parameter to get monitored. Now, whether you really require 6 patients or 8 patients or 8 days, sorry, in an ICU. And since we are talking of level 1, level 2, max level ICUs in the periphery, ALOS should be given to you. Everyday sensors should be given, right? So 6, 8 max to max parameter. And for that, I think we should not spend any money on EMRs, correct? Or an MIS where they register. It's simple template. The deck comes, the deck gets reported in a WhatsApp, right? Every day to certain core people. And then you monitor it, and end of the month, the unit has to submit an MIS. Based on that, you take. So it might so happen that, for example, Dr. Ujjwal might have 2 ventilators. And the utilization pattern has said that, okay, 1 ventilator had been hardly used. So why not pull up that resource and send to some other place where you might be requiring? Why 10 beds is required? So in a place of Vikarabad, where for the last 2 years, we have hardly 3 actually critical. I use the word, and I like Sir's word, actual critical care, which we all miss out. And that's one important aspect of impact matrix. ICUs operating in private domain and ICUs operating on social platform are totally different. You cannot have the luxury, because the more you keep the patient in ICU, the more you will bleed in a social environment. So these are the few points, and don't spend money on a robust MIS. Simple Excel sheet template goes out to the units, and the unit report it on a daily basis without fail.
Here is that CPR will develop some basic, reporting and standard.
Thank you, dignitaries, for that brainstorming session. Also hinting out that not only CAPEX is important, but OPEX should also be taken care of, because that would also ensure how the project is going to be sustained. So I'm going to call upon Dr. Geeta Bora, who is the founder of Spherul Foundation. She's won many accolades, has started this NGO way back in 2017, has been working with 15 states and 2 aspirational districts. And we work in almost all the 17 SDG goals. Furthermore, we're going to discuss as to what are the upcoming projects, how are the projects going to be shaped up, and so on. Over to you.
As always, when we come to the end of a conference, we come between us and dinner. So we have to be either very exciting or very boring. If we choose boring, we should be done in 2 minutes. If we choose exciting, we can take 10. So let me just introduce Geeta Bora to us. She is the founder CEO of Sperul Foundation, and she is the behind the scenes. She's the producer, movie maker, everything else and stuff. So we are just the front. And typically we don't do any of the work. All the hard work is done by her and her team. So first of all the success that we plan and all the work we're doing is thanks to her and her effort. So the question, I think briefly, just for everybody, could you just briefly in 2 minutes or so, tell us what you've done and especially focus on healthcare and how you look to see working with us?
Yeah, so in interest of time, I will just run through the presentation. If you can put up the slides. So basically, we started like any other NGO, mostly working in health sector during COVID. Before that, we were working a lot in awareness and those kind of stuff, and then health camps we were conducting, but we were not in any of the providing equipments or closely working with hospital. So the story started with pandemic, and most of the NGO story is like the same. So these are some of our past projects. We did during COVID, we did a vaccination of more than 8 lakh people, so that we facilitated. This is the COVID isolation center. This we started with the Honda India Foundation. Earlier we started 2 COVID centers, COVID isolation centers, and out of that one is converted to OPD. And if you see from 1st July 2021, we converted it to an OPD center. Until now we have almost more than 40,000 patients. So we had this OPD and IPD combined. And then donation of oxygen concentrators, beds, PPE kits. So this is something which I think that time every NGO was doing. So, and then there are, this is something, Healthy Highway project, where we used the deep learning and artificial intelligence tools. This is done through Vita. And there is another project which we did with Scanbo. So these are the AI tools with which it helps in basically doing health checkups, and immediately it gives all the vitals. So in this project, we covered around 4,000 truck drivers. And the other project was similar, like Scanbo. For that, we did pan-India kind of thing, and more than 10,000 people we did health checkup. And other than that, we are doing upgradation of PHCs. We are doing health camps in a lot of aspirational districts, but they are a different project and with other CSR partners. With CPR, we have done with Yagna. So they have actually given a very, I mean, the presentation was like, even I was hearing the figure, and this was something for which we wanted to see like what you are doing. So this presentation was like an eye-opener for us also. And this is the ongoing approved project. Out of that, this Cantonment General Hospital, which is in Pune, we have already signed the MOU with Kotak Mahindra Bank. So this is already there. And Mahi Mangeshkar Hospital, for this talks are going on. So we are, I mean, total fund raised will be 1.4 CR. So this is almost close. And then there are some projects in pipeline. We have identified 10 hospitals, and we are doing the due diligence for all these hospitals. So this is in process. And out of that, 2 hospitals, one is Dr. Hegdewar Hospital, and another, I think both the hospital were there last time in Symposium. So they are still waiting for donors, and we have to actually support them with that. And yeah, another slide, please. Yeah. So in 2023, we want to do at least 10 hospital and 1 hub and spoke. So this is something which we want to do. This is, I'm saying, minimum. If we can do more, then there's nothing like that. And yeah, next slide, please. So this is our ask for 1.5 CR. That ask is for 2022 financial year, March. And in 2023, from April to 2024 March, we want to do at least 10 hospitals, 7 CR, and 1 hub and spoke for 5 CR. So this is something which is there. Yeah.
Thank you so much, Geeta. That's fantastic. The effort that went into this is the due diligence, the program management, the project management, the follow-up, and the metrics of the impact. So that's the reason why I see the heart and soul of the whole project. So you can't hear us? Thanks, Geeta. And I think the effort that we're talking about, this is the core of the entire thing, the program that we talked about, the CIDS due diligence, the program management and the implementation, and the post-program management impact and metrics. The core of what Geeta does for us and the work we do. This ask that we're talking about is the minimum, like you said. We're looking to do something around 20 CR of work. And as and when we find new projects, we welcome them because we're looking for as many projects as we can do. I want to try and see that before we end the conversation, to open up for any questions from anybody, because we've been hearing for quite a while. We've heard some fantastic ideas and suggestions, and we had a lot of talk. So I would welcome anybody with any questions. Go ahead. So question for you, Dr. Satish, is, you got the question. There's the 40 lakhs that you have talked about for the spoke. Does it include OPEX? Okay, go ahead. Yeah. What about OPEX?
Obviously, there is no free lunch anywhere, right? Somebody has to pay for it. So even the operational expenses, what I was just discussing with them, let us say, assume that there are 10 spokes, and the cost of the spoke, yes. So two things, the CPR is going to give equipment worth maybe 40 lakhs to the spoke. Now, the spoke is going to use that equipment both for the free patients as well as their for-profit making patients. So let us say they earn X rupees from the patient, from a paying patient. So they should pay that for the IT person, as well as the biomedical, as well as the maintaining the equipment and the staff for that. It should be self-sufficient. There should not be any money transaction involved. But what happens is when it comes to the hub, you need a ICU on wheels. They are expensive. The ambulance with the ventilator is expensive. Even the other equipment, that not only more than the equipment, it's the operating people. For example, the manager. You need a good CO manning that. So that needs quite a bit of money. You need to have one person going around between each of the hub or between each of the spoke to see how are the equipment functioning. There's no point in having a biomedical person in each of the place. But let us say the hub is in Hyderabad, so they need to go to different places. So I worked out the cost. It was actually coming up to around 5 lakhs. It was the cost was coming up to 5 lakhs. So how do you do that? I'll be more specific and tell you exactly. Yeah. Let us say a good senior manager who is managing 10 spokes and a hub, nothing less than 1.2 lakhs for the manager. And an assistant manager who has to go around 60,000. the travel person, the biomedical person, and the IT and the data personnel, then the biomedical maintenance as well. The driver, you need to have 2 ambulances, and you need to have 4 drivers at least, day and night duties, and the diesel cost and the ambulance maintenance. So totally it's going to come up to about 4.8 lakhs a month. So that's quite a bit of money. So how do you generate that? So how do you get that into the scheme of things? So let us say hub has the equipment. So what we could say is some equipment could be supplied to the hub. So that could sort of, set off the expenses towards the daily management. And some money could be taken from the could be charged to the patient. I think these are the 2 ways. But if there's any more ideas that can be given, that's great as well.
Samay.
Yes.
Okay. So since it's a symposium, we are just discussing it. So my suggestion to this model is we should have the operating expense divided into 2 hubs. One is an unit ops, where there is a certain X amount which is mandated, required. And the manpower which you said is like a corporate ops, a person who has multiple roles into different. So I would segregate into 2, 3. I saw that CapEx distribution. I should say we should not invest in ambulances with ventilators. We have red ambulances and everything which can be tagged in, where the transportation cost, because it's a big investment among the CapEx apportioning. If you do, it's a huge investment. And apart from the CapEx, there's a huge OpEx, as you yourself said. So ambulance should be an outsource with a tie-up model for this hub and spoke, number 1, because now we have red ambulances, which are really good. Number 2, the cost structure is, if unit, there will be certain mandatory OpEx, which they will manage. And a portion of this, like a 5% or 8%, suppose if you say the resources which is doing work for all the units, that has to get apportioned to each and every unit. And then the cost should be allocated in that way. So the way, if we take out the ambulance part of it from this scheme of things, and we keep it outsourced, and easily a patient who is getting admitted into a rural part, correct, and coming to an hub, think otherwise, if he or she would have hired a private ambulance, would have also paid, right? So maybe we can have a tie-up with red ambulances, bring them as I'm just quoting a name of them. They can be a partner to this program, right? And they can also they also get the mileage of it. There can be some concessional tariffs being given. So if we have this type of a rational investment, the initial CapEx will also come down. Coming back to the other part of the CapEx investments, we can also approach biomedical equipment companies for pay-per-use models. Why should we buy a dialysis machine? We can. Or there are a lot of companies who are now giving monitors on a daily rental basis also. And sir left, I missed out one point. You asked a very one question. What MIS? I think CPR should have all digitally tracked assets. The asset register should be digitally tracked, which should be a part, because you don't know where the asset lies. And since you will move an asset from one location to other location, the asset tagging has to be, and sir is an expert. So we can have a code which might show where that asset is moving. So if we have this, I think the operating cost would be low and your initial CapEx requirement will substantially come down. So that's my opinion.
Absolutely, that's right. Yes, please. No, one more point.
First of all, I thank everybody to be here and discuss, really doing something for the society of India. It's a great opportunity for me also to be here. I would like to mention one thing about what you mentioned just now. Red ambulance do not have the facility all over, tertiary areas like, district wise. Yeah, no, I'm just sharing that. On top of that, it's a commercial organization, very much commercial organization that I can tell you because I am into this field, especially ambulance. I manufacture ambulances. So the best way is to take a major advantage of 108 because they are available in every small districts and they are well equipped even if compared to 108. Red ambulance or any other private ambulances. So it is better to tie up with 108.
See, there's one problem here. Whether it's 108 or red ambulance or whatever, nothing works for pediatrics because see, when am I bringing the child to the hub? Only when shit hits the roof. They are bad. They have to be ventilated.
Yes.
So that means the child is already on the vent.
Yes, sir.
So I need a transport vent in the ambulance.
Absolutely.
Not possible.
Absolutely.
For whatever options you've given, number one.
Yeah.
Number two, if I have a newborn baby, I have to have a transport incubator fitted into the ambulance.
Absolutely.
So
Yeah.
that is the two reasons. If we are transporting level 1, level 2, I completely agree with what doctor has said. You could use them. But when you're wanting to transport the other ones, maybe, I don't know what red ambulance does, but we could equip 1 or 2 red ambulances with all these facilities and do it. We could work on all those things.
So I was about to say that.
We could work on those things.
See, there might be some organizations like 108, as per I know, correct? They don't have where you can transport acute with ventilators. Those are more like patient transport vehicles. Nobody has it.
Nobody has it.
Yeah. So. Yeah.
Yeah, I know Ravi Children's Hospital. Yeah, I've had a chat with him. Yes, yeah, I've done that diligence. But only thing, as I said, it takes a lot to treat the children, but it's not as remunerative as as it should be. So that's the reason why we're thinking, how could we do it in a different way, so that the burden doesn't go to the sort of the family. At the same time, we're doing something good. So exactly, I agree with you. Trip, yeah.
So I fully agree. Yeah. So there is, as Sir said, there is nothing free. But as a group, I just use the name.
Yes.
We can bring them as strategic partners into it.
But the problem is, it's like this. See, if you, let us say we take a red ambulance, using the same name. See, there is some, he knows because he's in that industry. There is a lot of changes that need to be done to the place which holds that to have a transport incubator and a transport vent. So that has to be fitted, it's specific for children. So that's the difficult part. So you have to put more effort and energy into that. And as I said, it might not be that remunerative, but that's how it works. That's how pediatrics agree.
2 more questions if anybody has. So we can end at the West, but one of the things that we have learned today is there's a lot more to learn. And we are definitely going to keep learning. We're definitely going to keep looking. We're definitely going to keep innovating. And the cost structures, making it viable, the metrics, there's a lot to do. So thanks everybody for all the inputs. I would like to invite Dr. Satya to come and give the vote of thanks.
It was a wonderful discussion. I think we got a lot more than what we asked for. So I would like to start thanking first the Raj Reddy Institute for letting us generously use their facilities. This is the second time they let us do that. I also appreciate all the audiences here to come and listen patiently to our passion and vision, where we are going and what we are doing. I'd like to thank my all our working partners, starting with our AIMS project, Dr. Maheshwar Reddy and Kiran, and our EGNA group, and also Dr. Satish. Thank you. Thank you to my wife for supporting the cause. She's been very patient with me. She's here. Thanks to all the panelists, Dr. Shibaji and Satish and all of you. I really thank that. And thank you, Spiritual, for working with us. And above all, I need to thank two people, because when I called them, they thought that this is a complete madness, but somehow I pulled them back. Krishna and Uday, thank you for joining with my journey. Yeah, Seshu, and I cannot say enough. You do all this legwork, wonderful. All the people who worked here, Ajay Naik, Uday Naik, and Romaji, and all of you, thank you very much, for doing all the background work for us. Thank you. Oh, kindly join for the dinner. Yeah. Any photo shoot? Yes.
Yeah, we'll have a photo shoot. Thank you.